Testing 1, 2, 3. Board of Education meeting, July 15th. Emergency Board Education meeting, July 15th. Testing 1, 2, 3.
Testing, testing, 1, 2, 3. Testing, 1, 2, 3.
Got it. So who cues me when we're ready to go? Okay. Good evening. I now call the July 15th, 2020 emergency meeting of the Charlotte-Mecklenburg Board of Education to order. Madam Clerk, do we have a quorum?
Present.
All right. I will now entertain a motion to adopt the agenda.
So moved.
All right. A motion from Ms. Byers-Belli. Do we have a second?
Second.
A second from Ms. De La Hara. All those in favor of the motion, please raise your hands and say yes. Yes. Any opposed? Oh. Okay. So that passes 8-1. I just want to thank everybody for being here and for tuning in tonight. We are meeting at Mallard Creek High School in the auditorium. We're masked, we're social distancing, but a lot of people have pointed out that if we're even considering an option that brings teachers and students back into classrooms, that we need to be together as well and not be on Zoom. So that's why we are doing it this way. But at the same time, there are still public safety restrictions on the total number of people that can be in a class, in a room at a gathering, and there's quite a few of us when you count all the presenters as well as everybody around these tables. And so that was why we were not able to open this up to the full public. So we're still streaming. But anyways, that's why we're here with masks instead of on Zoom today. We're now going to have a Mecklenburg County COVID-19 update, and I turn to the superintendent for this update.
Thank you, Madam Chair and board members. Good evening, everyone. I would like to invite our dear and close partner, Ms. Gibby Harris, who heads our local Mecklenburg County Public Health Department, to share some words with our Board of Education and members of our public, and then also give our board members an opportunity to ask any questions of Ms. Harris.
About this. Oops, sorry. That helps, doesn't it? That's almost too loud. So there's nothing. The guidance, what we understand about this virus, continues to change. We continue to learn, and we continue to have to change our guidance and the way we operate based on what we're learning as we go. And that's been true for the school systems as they've been planning, trying to think about what this fall would look like. When you think about reopening schools, there's all kinds of issues that impacts. There's issues of our parents and those folks that need to work. There are issues that I'm concerned about with a number of our kids who will not get the instruction that they need if they stay at home just because their parents aren't able to provide it for one reason or another. And there are concerns about parents being able to work. But there's also the concerns that I understand you're hearing from teachers and from the people that work in the schools about their safety. And the list goes on. The list goes on. And we all have had numerous conversations across the country about our concern for our children and whether they're able to learn well in the virtual environment. What we're seeing here in Mecklenburg County, and it was in the data that I sent to you, hopefully you got it today. Those trends include the positivity rate, which is the number of positive tests based on the number of total tests that are done in the county. Unfortunately, that number is not perfect because we don't get the total number of tests from some of the testing sites. So we're using data from our 2 hospital systems who do most of our testing, and we look at their positivity rate. Our positivity rate has been hanging around 10 to 11%. It's not good. We want it to be lower, but it's been somewhat stable in that area. Some days it goes up, some days it goes down. We look at it over a 7-day average. So we're watching. It's staying fairly stable. We're testing a lot more, so we're seeing more positives, which you would expect. But the positivity rate is staying fairly stable. We also look at the hospitalizations that we are seeing. Those hospitalizations have been ticking up since the middle of May. It's been a slow rise, sort of a steady rise. Our hospitals have been able to manage it to this point. They have very specific plans in place, and I know you have some folks from both the hospital systems coming a little bit later this evening. So they'll be able to talk about some of that in more detail than I can. But we watch that data on a daily basis as well. We look to see how many patients total they have in the hospital. We look to see how many COVID patients they have in the hospital. We look to see how many of those are in ICU beds and how many of those are on ventilators. And to date, the hospital systems are managing that well. Luckily, over the last month or so, their census rate has gone up, but it's because they're bringing in those folks that had been putting off health care because they were afraid of coming into a facility and getting COVID. So these folks are coming back in, they're getting the care that they need, elective surgeries, those sorts of things. But the hospitals have the capacity to close that back down again if they need beds for COVID. They also have surge capacity. So we're watching all of those things very carefully as well. Obviously, we have not seen, at least at this point in time, some of the things that are being seen in other parts of the country, especially the South, where the rates are going up significantly and hospital beds are being filled. Another thing we watch very closely is the number of influenza-like illnesses that are seen in our emergency departments across the state. Typically, this time of year, we're not seeing a lot. We're still not seeing a lot right now. It's higher than it has been because COVID is sort of being pitched into that number. Typically, we see that go up significantly once we get into flu season. So flu season is the one thing that has me terribly concerned. I think once we get into flu season, we're going to need to make sure that we get as many people vaccinated as possible because it just complicates the whole issue with COVID. Because when you've got a child in a school or you've got somebody at work and the symptoms are fairly similar, there's some differences, but there's similar symptoms for flu and COVID. You're not really sure what you're dealing with. So those are some of our issues right now. The other concern that we have is testing and having enough testing available. If we, as we open up schools, whatever decision that y'all make around that, I would love to have rapid testing available so that if a child or a teacher or someone that works at the school becomes symptomatic, we can test and know immediately what we're dealing with and manage it quickly. That would make a huge difference in the school setting. Right now, we don't have ready access to that. We did have the CDC director here earlier this week, and we talked to him about that. He is pushing hard to make that rapid testing available, readily available, because he knows that schools need to open. But I can't tell you when that's going to be available to us. It's something, again, we have to watch. So it's all part of that evolving world of COVID-19, which makes it challenging to make decisions because so far nobody's crystal ball has worked very well. We make decisions based on the data we have and what we're seeing in our communities. The other thing that I will mention as well that we have experienced here in Mecklenburg County, the governor creates his orders and his guidance based on the entire state. Mecklenburg County doesn't look like a lot of the state, and we have much higher numbers than anyone else in the state. And that impacts how we take his guidance and translate it into action on the ground. So I know as you make your decisions, you will do the same here because his guidance is important for the whole state to have, but then we have to customize it to make sure that it works for Mecklenburg County. So I will stop there. There's much more I could say, but I think I'd rather allow y'all to ask me any questions that you might have that might be helpful in your deliberations this evening.
Thank you. Before we go to questions, I just want to thank you for making the time to join us tonight. This is incredibly important for us to have some time to ask you questions like this. How much time do we have with you, just so I can make sure we use that wisely?
I am good until about 6 o'clock. I've
Oh,
got a
wow, okay.
webinar I have to be on at 6:30 this evening.
Okay, well, we won't take that much time, because we have a lot more to get through.
Yeah,
but,
you do.
But, so, colleagues, let's do one round of questions, and then not everybody has to ask a question, but if you have a second question, let's give everybody a chance first, and then do a second round. And I see Ms. De La Hara.
Thank you, and thank you for being here with us this evening. My concern is about the testing, and you mentioned that the CDC director, you had encouraged him, or he was encouraging that we move with more rapid testing. Can you explain any more? Like, did he indicate what the challenges were, or if he had any dates or information, and how that would be funneled to you when we do have access?
We don't have any of that right now, unfortunately. One of the challenges we're having right now is with the increased testing we've been doing, the labs have been backing up. So the turnaround time on testing has increased, which is not good. I mean, if you get tested and you can't get test results in 48 hours so that you know what to do with it, it becomes a problem. And right now, some of our test results are coming back in 5 to 10 days. So I do know that at the federal level they are working on it. They have a platform for doing it. The question is how quickly they can ramp that up and then get it out into the communities, and we've really not gotten much information on that yet. He understands that that particular type of testing is critically important to how well we can manage opening schools. So I do know that they're putting a lot of emphasis on it right now, but we've had challenges with testing around this virus so far in this country, so it's hard to count on it at this point.
All right. Ms. Schiff? Microphone.
Thank you so much for being here. I really appreciate it. I kind of have a similar question, but want to know, as we talk about we don't have the testing availability, what would you think that protocol should be in the schools? Because the first time we have a child, if we're talking about even temperature checks, and we know that's not as valid, but the first time we have a situation with a child that's sick or teachers that's sick, what would you recommend in terms of protocol? What should that look like as a school begins to see this?
So that's a good question. I think the first thing I will say is I think one of the things that helps us in this county is that we have a fairly robust school health program. So you will have nurses in your schools that can respond to those types of situations, and will have worked through with the school what the protocol is. Typically what we would recommend in that situation is removing the teacher or the child from the classroom immediately if somebody develops symptoms while they're in the classroom. And at that point, depending on how ill they are, of course, we'd contact the parents and try to get the child tested right away. If it's a teacher and many people have mild symptoms. They're not severe. And that teacher could get in the car and go straight to a testing site and get tested. So that would be the first thing we'd recommend, is let's get a test done as quickly as we can. As soon as we get them out of the school environment, get them tested as quickly as we can. And that school nurse, most of our school nurses have been doing case investigation and contact tracing this summer. So they've got lots of experience with that, and they will have access to the systems that they need to get these things done.
So we would definitely need to have a nurse in every school working with this, and then that contact tracing is important. Would we then begin to decide how many others would need to also be moved out of the school to go for testing as well?
Exactly. And one thing I will emphasize, and this is what we're doing in our work environment as well as working with law enforcement and fire and rescue, and even with the hospital systems, if people are masking appropriately and social distancing, it really cuts down on the number of people that you have to worry about in terms of contact. And I think that's the point that I've been trying to emphasize. I mean, several things that we want to happen. We want our hospital systems to have the capacity to deal with the individuals who are sick. We want people to be able to work, and we want kids to be able to go back to school. And if we do the things that we know we have to do, we can make most of those things happen. So if people wear masks and social distance, don't get involved in large groups, and do what you need to do out in the community, but don't go to bars and restaurants until the middle of the night with a bunch of people without masks on, or get into large congregate meetings with people without masks on. There's things we need to do, and the reality is this virus is not going away. It's going to be with us for a while. Unfortunately, it would be different if we had a vaccine or a cure or treatment even. We do have some treatment, but not a full spectrum of treatment. But we don't have those things right now. So we have the majority of our community who still is vulnerable to this virus. So that being the case, we have to do the things that we know that work. And those are the things that we know that work.
And would we send out letters? I know in the past we've done that. I've been in the schools as administrator. Would we design, because this is important too, a letter that would then go home with the rest of the people who would come in contact with that, especially to the children and families?
Yes, if there's a situation where others have been exposed, we would be notifying them just like we do with any other communicable disease in the school system.
Just wanted to verify that.
Okay. Ms. Sawyer, and just FYI, colleagues, if I don't see you, make a noise or something, because I'm having a hard time seeing everybody. Okay. Did you have your hand raised? Okay, Ms. Chi? Okay, Ms. Sawyer?
One of the challenging things from a decision-making perspective is that while some states have given specific guidance on metrics that are for in-person school, others have not. The state of New York, I'm sure you're familiar, has set a target, which I guess is consistent with our positivity rate. They set a 5% target, and we're now twice that. Are there other metrics that you would look at to assist in decision making, or is there a point at which, is there a metric at which you would say we can't have school? Is there a point at which you would say absolutely schools need to close, and what would that be?
I don't have a specific number at this point. What I would tell you is if we see our positivity rate starting to climb, if we see significant increases in our hospitals, even though they can manage it, that just means we have more people who are ill and need to be cared for. I would be concerned and would think that we would need to start having conversations. The reality is, and I've been working with the school staff for quite some time on these issues, and I work with businesses around this issue. I work with others in the community who are trying to open up lots of different things, and I said, happy to work with you on your plans, and we can have best case scenario, middle of the road, but you've always got to have that contingency plan, and you've got to be able to put it in place rapidly if we start seeing issues. So it's important to have all of those plans in place. I think that, 10% has been sort of in the country has been the number that people, you don't want to get much above 10%. But we're seeing places right now with 25 and 30% positivity rate. We haven't come anywhere close to that at this point, but we watch it very closely.
Okay, thank you.
Mr. Schul, do you have any questions?
I was just wondering if you could maybe offer us, quantify exactly what is the risk of students staying in a classroom for 8 hours in a closed environment with masks 6 feet apart. Is there an increased risk compared to what we're doing right now? Maybe just some guidance about what is the risk looking like? What are we getting ourselves into?
Well, the studies that we're seeing right now, I mean, as you know, especially if you've worked in a school setting, that children with most upper respiratory infections are super spreaders. You talk about the flu, you talk about colds, you talk about all of those sorts of things. Our children are super spreaders. It goes through classrooms, it goes through homes, and the children quite often are what's bringing that back to the homes. What we're seeing with COVID-19 right now is that children are not proving to be super spreaders of COVID-19. This virus has been very different than most of our respiratory infections that we deal with on a regular basis. So we're seeing that children are not necessarily the super spreaders that we thought they probably would be, because that's what we experience with other viruses. Probably the bigger concern in a school setting right now, well, number one is you have the challenges of children wearing masks all day long. I know my granddaughter is going to be a real pill for somebody to have to deal with, because I doubt seriously she's going to gladly wear a mask all day long. But I think we definitely need to protect, but also to keep teachers and other staff masked so that they're not introducing anything into the schools. Setting as well. That's just as important. So I think if there's social distancing and the children are masking, based on everything we've seen so far, that's the assumption at this point. We might learn differently by some places that do open up and bring kids in, but right now, based on all of the evidence and the research that's been done, that's what we're seeing. But there's a lot of ifs there. I understand that.
Turn on your mic.
The other night I was watching TV, I think it was 2 nights ago, and I've been watching the what do you call it, the rate just kind of meander. And I don't know if somebody's put the wrong map up, but it looked like that thing had jumped, and it scared me. And it scared me because I knew we were going to be having this conversation. And the next night, I guess which was last night, it didn't look like it had gone back down. I don't know if it wiggled up a little bit, but it, and that thing can change from day to day. So we could sit here tonight and make a decision based on the testing today, and then tomorrow it could jump. And then we would. How do you think we should evaluate what you're saying? One, you're telling us it's fairly stable right now, and then we go home and the news reports say something different. And I'm looking at local news. I'm not paying attention to the national news or what the other guys are doing. I'm looking at local.
I will point out that one of the challenges we have is our data, because the state reports the numbers and we report the numbers, and they don't always match up. So that's one challenge we have, and that's a reporting artifact. The state gets the positives for anyone who tests positive in Mecklenburg County. There are quite a few people who test here who don't live here. We track residents because that's who we're responsible for. So our numbers look a little bit different from the state numbers sometimes. You'll see the Charlotte Observer, I think, had us having .400 cases 3 days ago at residents. Those were the positive tests going up and down fairly significantly because it depends on how many tests were done on a certain day. Some days, the systems that test in Mecklenburg County test more people than other days. When you have more people being tested, you're going to get more positives. So that number bounces around a lot. That's why when we look at the positivity rate, those tests done are positive. And then we average it over 7 days. That gives us an idea of how that trajectory is working. And when I say stable, down every day, it's that 7-day average of what we're seeing.
Now, you were saying the testing, but if you're talking about just the tests that happened today, you won't get the results of those tests. You just did a test.
Yeah, and so what we report are the tests that we get in. So that's the other challenge we have, is the way the system works is the person gets tested, it goes to a lab, the lab results it, they send that information to the state, so there is a little bit of a lag there. It's improving some, but there is a little bit of a lag before that gets back to us, and that's what we can report.
So the rate that I'm seeing tonight was what really happened a week or more ago.
It's possible, some of it, unfortunately.
Thank you.
Mm-hmm.
I'm going to remind us all to kind of keep your microphone near your face. We got so used to Zoom, we're forgetting how to use mics, but some people around the table are having a hard time hearing, and I've heard that folks watching us at home are having a hard time hearing as well.
Thank you.
Turn your mic on.
And
Tip it down towards your face.
Oh, okay.
The analog.
Classroom
Put yourself off mute.
environments are important, and our schools are at various levels in terms of age and health. And quite frankly, I visited some of our schools that you can't open windows, the HVAC is not in good shape. Talk to just a bit about the type classroom environments would be considered the safe environment for children.
You make a great point. It's important that the HVAC systems work well in the classroom. I haven't had specific conversations with staff about where there may be concerns around that and that sort of thing. I know that there's work that's being done to try to improve where there needs to be improvement. But, you do want good air circulation in the rooms. While even though you've got masks on, you just want that circulation in the room. So the perfect environment, obviously, is an environment where people are 6 feet apart the majority of the time, and that everybody has a mask on, that the HVAC system works well, and that there's not a lot of sharing of stuff. That's the optimum situation.
Thank you. Mm-hmm.
All right, Mr. Strange?
So thanks for coming out. It was really important for us to have this conversation in public with you, to really understand in terms of our public health, our regional public health, what that looks like, not just in the county, but around a bit as well. And this virus knows no boundaries.
Exactly.
Neither does any other virus, if I'm correct.
That's correct.
So what I've heard you report is that the positivity rate is staying relatively stable. What does that mean? I understand the words, but what does that mean in terms of the health of the people of Mecklenburg County?
It's a mixed message. I'll admit that. Unfortunately, it's the best we have right now in terms of data that we have available to us. One of the other challenges with this virus is that there are quite a few people who are asymptomatic or have very minor symptoms who are still shedding virus. And many of those folks have not been tested don't know that they're infected or that they're potentially infecting others. That's one of the challenges with this disease. What the positivity rate tells us of those people who are being tested, that the percent of those that are positive, that's the positivity rate. It gives us sort of it's a surveillance tool to help us try to figure out to some extent what's going on in our community. The fact that so many people are infected and asymptomatic has made this particular virus a little challenging to understand fully and to track fully. The only way to do that as well as we possibly could would be to have a lot more testing available in our community. And we've been trying to increase the testing in Mecklenburg. The state's been trying to work with us on that. But if we can't get the turnaround time on test results down to a level where it's reasonable, it doesn't make really need to be tested.
Sure.
So we're in it is, like I said.
Sure. So if I understand it correctly, if we double the number of tests, test twice as many people, and the positivity rate went down roughly in half, all that's telling us, so the positivity rate that's being tracked would have been cut in half, but it wouldn't change the health of the public at all. Is that right?
So here's how I would frame that. Again, what the positivity rate tells us is, gives us some idea of the percent of our community that's infected at any given time. I have said more than once that we are not going to test our way out of this. We are not going to test our way out of it. If we have it in a timely fashion, is help us be in touch with people who need to isolate and quarantine so they can't spread it. That's what it does for us. The only other thing that testing does for us is, from a surveillance standpoint, sort of understanding what's going on in our community. Things that we have learned is, that we have certain populations that are more impacted by this right now than others. And that gives us an opportunity to do more education and to make sure that testing is available in that community. But it doesn't tell us fully what's going on here, because we just don't have the testing available to do that. But testing alone is not an answer to anything other than just giving us an idea of how many people might have it.
Right, and I think that's what I'm trying to understand about that positivity rate. If we did have an opportunity, and we're certainly, as you described, making every effort to increase the level of testing, the expectation is we would increase the level of testing. It doesn't change the health of the population at all.
No.
But if you increase the level of testing, the expectation is that the positivity rate would go down. But that doesn't change the actual health of the public at all. Right.
The health of the public is going to be changed by all of us doing our part. Wearing masks, social distancing, washing your hands. I mean,
right.
That's
our behavior, right?
Exactly.
As a public, it's down to us to change, not the positivity rate, but the health of the public.
Exactly.
And whilst it's some indication of the health of the public, again, it's also completely dependent on how much testing we're doing. If we cut the tests in half and targeted those tests, then the positivity rate would go up.
Would go up.
But it also wouldn't change the health of the public.
No, it is.
Right?
It is a measure in time,
Yeah.
and it is. It's not the only measure we can look at. I mean, it's not going to give us an answer.
Okay.
We have to look at more than that.
So perhaps we can. Oh, okay.
So, Dr. Harris, I'm a nurse. A couple of doctors sitting out in the audience know me. I worked with them in the ER at Presbyterian for a number of years. So medical stuff isn't foreign to me, and neither is the talk. So some of the things that I most am concerned about, I listened to you and Dr. Redfield speak the other day, and one of the comments was that you thought it was time to open schools, and you gave some parameters and some reasons why you thought schools could open. I listened quite intently to that. What I'm mostly concerned about is trend, some other things, but the trends that I see, things like I want to talk to the hospital doctors about length of stay, which indicate trends in improved treatment protocols. I wanted to know if there's any correlation between the death rate and the increased positivities or increased positive cases in general, because I've noticed the death rate in Mecklenburg County is relatively flat, even though our number of new cases is increasing. I know our hospitalization rate is relatively flat, even though the state of North Carolina has gone up pretty exponentially since about May 15th. We were around 500, and now we're around 1,100 statewide. So I want to kind of I feel, is it two things. Is it incongruent that our governor said we have to stay in phase 2 yesterday, and he then said we can also open schools? Are those two things, how are they on the same path? So I'm a little confused by that. And then what would the key indicators be to you in all those different trends that we're measuring, all the different, so many different graphs, so many different box graphs, pie charts, you name it. I think you used every different option available when you sent us that data. It's quite impressive, because I get bored easily if they all look the same. What district that are not health experts, when we should pivot from one plan to a less or more restrictive plan? What would be the key indicators that we angst is, oh my God, there was then be less restrictive. So what would those key indicators what should they be?
Okay, a couple of things. Number one, I think you make some good points about our death, our fatality rate, illness. The other thing that we're seeing here that makes us a bit different from some other places is the fact that the majority of our cases are in younger populations in Mecklenburg County. So that less severe illness. There's a few things that we're watching. Hospitalizations are one of them. Obviously, deaths, we're going to always keep an eye on that. If we see spikes, we'll have concerns. Positivity rate doesn't tell you anything by itself, but it is one of the indicators that we're watching because we can look at trends. And I mean, I don't know that a school system would want to do this or not, but we can also look at where we're seeing spikes and in what populations we're seeing spikes, and that might have some indication about where you may have specific concern.
And I do think I sent you a few questions, and one of them was that, where if we see an outbreak in a specific age demographic group, what are their correlations, where are their commonalities?
And we're trying to, again, data can be challenging because the data that's coming through from the labs isn't always complete. But we're trying to between hospital data that gives us one piece of information, some of the pieces of information, we try to piece all that together in a way of really painting the picture in Mecklenburg County so we can address things sometimes in a community level.
So did the picture that you and Dr. Redfield paint on Monday, did you guys actually say that it was okay? You thought that where we were right now meant that we were okay to open schools at some capacity?
So here's...
I just wanted to make sure what I heard on Monday. I just wasn't sure.
Dr. Redfield was pretty adamant about schools.
Okay.
I will say that. He has major concerns about the increase that we're seeing nationally in teenagers in suicides, the increases nationally that we're seeing in teenagers in overdose deaths. He has concerns about whether we're seeing drops in the number of reports of child abuse, because we know that teachers recognize a lot of that, and if kids aren't in school, that doesn't mean it isn't still happening, it's just not being reported. So he has concerns about things like that, and he's really worried about the public health of the children in a bigger sense than just COVID. So he was pretty clear that he thought we were good to open schools. My perspective on this is the governor stopped us at phase 2. I'm pleased with that. I'd much rather focus on what we can do with schools than other things that we can open up in our community. We have to start making choices about where we put our emphasis and what is most important to us as a community. And I think, we want people to be able to work. We want parents to be able to get their children in school. We want children to have the opportunity to be in school. And whatever we can do to make that happen, I think we should focus on. Now, whether that means we're ready in Mecklenburg County or not, I can't make that decision for you. But what I can promise you is that the health department will work carefully and regularly with the school system to monitor the situation and to provide input and to assist in any way we can, regardless of what your decision is.
Okay. Ms. Marshall.
Again, thank you, Gibby, for being here. We have a number of folks that are certainly concerned, staff that are concerned about their own health, and they're concerned about their family's health. I would like to just have you spend a minute talking about underlying conditions that you think are the most troubling and things that we can do to treat those, what we see and what we've learned so far to be able to handle that. And I'm thinking about staff that may have asthma issues, staff that may be diabetic, those sorts of things, and then certainly those folks have that in their families. So just in terms of what you see in Mecklenburg County that, and how we treat that here in our hospitals with COVID.
So obviously the majority of our deaths have comorbid conditions, and those are the folks that are most affected by this virus, most negatively affected by this virus. The things that we worry about are respiratory illnesses, diabetes, heart disease, immune compromising conditions. Those sorts of things put people more at risk. And I know, I'll just give an example within county government. We have been working with those staff that are in those sorts of situations to try to let them work from home so they're not being exposed. The county really hasn't opened up significantly, but from the public health perspective, we've had large numbers of staff that are still working because of some of the services we provide and the contact tracing we've been doing. So, but we do have some of those folks that are working from home. So if you have individuals in that category and there is a way for them to be part of whatever virtual learning you're doing and not bringing that back into the office, that would be a good solution, I think, for a time being. And especially, if you decide to open up the schools at any level, especially in the beginning while you're sort of testing things out and seeing how it's working, allowing those folks to continue to work with home would be a good option if it could be done.
Thank you.
So I'll ask my question, and it's a bit of a follow-up to something that you said earlier. And I'll just lift up that a lot of the national and even state guidance on how to safely reopen schools has focused on children. Do not seem to be super spreaders and don't seem to even catch it as intensely, except for in a certain, I know there's a certain inflammatory version that some children are coming down with. But that sort of leaves out the adults in the equation, and we do have 19,000 adults associated with our school district. And I think there's just been an extreme amount of concern amongst our adults. And so I wanted to follow up on your question about contact tracing. So if someone tests positive and they've been interacting with, their small cohort of socially distanced children, and or maybe children, I'm just trying to think of a real life example in a classroom. Someone tests positive, there's some kids, some of them had occasionally had their masks off or not, or someone actually came up and gave you a hug before you could stop them. There are other adults that you've been interacting with who have been wearing masks. Do you have to, how do you identify who else is exposed? If everybody is masked, does that mean they're not exposed?
So that is another piece of guidance that is continuing to evolve as studies are being done and research is being done around this. In conversation with Dr. Redfield, there's some new guidance coming out. The problem is we never know how quickly it's going to come out, so we're still, we could be waiting on it for 3 weeks. I don't know. But there's some new guidance coming out that will probably indicate that if you are in an environment where everyone's wearing a mask and everyone's social distancing, you really should not have to worry significantly about exposure to someone who tests positive. Now, what that means is you have a teacher who tests positive. The questions we would ask is, were they symptomatic while they were in the classroom? If they were not symptomatic, then we would handle that differently than if somebody was actually, and the time frames would change in terms of who we think might be exposed. And we would be asking questions about, well, did everybody have their masks on all the time? Or were there times when masks were off, people were potentially exposed? And then we'd make recommendations on what kind of exclusions we would need to make based on that.
So contact tracing is evolving.
It is evolving. The guidance on exactly who is exposed is evolving.
And we think that if you are symptomatic and you test positive, that you are more contagious than if you are asymptomatic and you test positive?
That's why.
30, and I know I promised every question. Yes, Mr. Strain.
Thank you, Madam Chair. Gibby, when we started this back in March, there was a call to flatten the curve. Mm-hmm. What does that mean? What did it mean, and why were we talking about it? What was the objective of flattening the curve?
The main objective of flattening the curve was to make sure that we were able to manage the number of people who would need to be hospitalized, and to make sure that the hospital systems were able to manage what was coming. And at that point, we were looking at lots of different modeling. There were lots of different projections about how bad this would be. And the thought at that point is if we could slow it down, we knew we couldn't get rid of it. If we could slow it down and manage it, then the hospitals would be able to function without having to look at surge capacity or building a field hospital or whatever we might have to do. And so that was the intent. That was the main intent at that. You know, it didn't go flat, but we didn't expect it to go flat. But closing down again. So my concern for months and the vaccine, friends and neighbors and everybody you have any influence over to make sure they're wearing their masks and socially distancing.
So we were successful in flattening the curve up front, which great result, right? Mm-hmm. Saved lives, undoubtedly, right? Obviously unfortunate that we've lost those that we have. Mm-hmm. But it would have been had we not, at this point, manage it is the most important, I believe. That's certainly what we defined up front, and I think it still is.
The flattening of the curve not only allowed the hospitals to manage what we were seeing, it gave them time to build out the capacity that they may need in the future.
Thank you very much.
You're welcome.
Yes, I had actually said yes also with Mr. Strain, but I'm going to just, there seems to be a desire to move on, and I'm just going to let it go.
You sure? I mean, for
said
sure
the
if
word
we
that
have...
I still
Be
have
happy to answer them.
And with Ms. Shipp's question, if a child, had symptoms or anyone had symptoms, and we described that they would go see the nurse, it occurred to me, and I guess we can correct me if I'm wrong, it was my understanding that while our intent was to always provide nurses at all of not being able to have enough nurses to be employed in all the schools, that we at least this past year, I'm not sure historically how that has run, but we are actually unable to have nurses in every school, and sometimes they're splitting between. Have you any indication that that would still be the case, or got any feedback on the potential school nurses? Because if we don't have nurses for every school.
We are actively recruiting right now for the vacancies that we have. We also have a limited part-time pool of staff that can fill in gaps that we have. All of our school nurses have been working since March doing contact tracing. We're pulling them out of contact tracing so they can go back into the schools. We're doing everything we can to make sure that we've got a nurse for every school. There may be occasions where we're not able to do that, but we're doing our best to try to recruit and make sure that we have that available.
Ms. Cheek? I'm going to go ahead and ask Ms. Dash. You said it would be okay for a brief question. One thing that you brought up during answering questions with Mr. Strain, you said that you don't want to have to go, if we go to lockdown, we need to, or you kind of want us to keep moving forward. To get where that doesn't really help the county our healthcare systems or the medical community. Figure out how we're going to manage.
Depending on who you talk to, but it's going to be.
We're not going to know we can do it until we do it.
That's true.
It's a little bit like when we used to pull chest tube out of a paper.
Figure out, and we're learning as we go. Sometimes you don't, you know, it's got to be both and.
Much, Ms. Harris. This has been incredibly valuable to our decision-making process. For your time
Appreciate
today.
the opportunity to be here, and I wish y'all luck tonight.
Thank you.
Thank you. Thank you. All right. So we are now going to have a presentation on the voluntary full registration. And I turn to the superintendent for this presentation.
Thank you, Madam Chair. And I want to thank Ms. Harris once again for providing the overview on COVID-19 as things currently stand in Mecklenburg County. And I want to thank you for your long-term partnership. All of us in CMS are and they've already made their way to the podium. I'd like to introduce Dr. Frank Barnes, our Chief Equity Officer, and Ms. Kim King, our Director of Virtual Learning and Media Services, who will give us a report on our full remote learning option. Thank you all in advance.
Thank you, Mr. Superintendent, members of the board, and Chair. At the onset of our work to prepare for the opening of school, we began to prepare for any type of public health condition. And we were preparing in earnest to be able to educate students whether the virus had been contained, the virus had been slowed, or there had been a recurrence of the pandemic. However, we knew no matter what the public health state might have been come this fall, that there would be some members of our community, some of our families that we have the privilege to serve, who would not feel comfortable sending their children to school. And it was at that time, Ms. King began to work with a team of people to develop what we're calling the Full Remote Academy, to offer that option to our families to be able to send their children to school safely and receive a sound education no matter the public health conditions. Our purpose of presenting to you today is to give you an overview of the Full Remote Academy and to answer any questions you may have. With that, I'll hand things over to my colleague and we'll join you at the conclusion of the presentation.
So I'd like to
Sorry. Oh. I'd like to start out by telling you a little bit about what this full remote academy will look like. So first, we have a district remote learning plan to evaluate our curriculum, instructional delivery, and assessment of that curriculum, to drive that in each model. And this full remote academy will follow every piece of that district remote learning plan. Just like all of our other models, it will follow the elementary, middle, and high school instructional guidelines for this year so that students will receive equitable instructional opportunities in each model. Students will remain assigned to their currently designated school with the possibility of some cross-enrollment within K-8 if it is needed, and Dr. Barnes will address that in an upcoming slide. This academy will be taught by teachers who are assigned and dedicated to the full remote academy in K-8. So this isn't something that is happening after the school day, after everybody else goes home. This will be available to all students, working closely with our EC teams, our ESL teams, our talent development teams, as well as all componentity will be able to opt in and receive the services that that child needs to be successful. Families will be able to exit the academy or enter the academy during the upcoming registration window and then mid-year at the end of the semester. So we don't want to have people in and out because that would create upheaval with staffing in both models, but they will have an opportunity to go to a different model in the year in December. And the program is set up to be 30 to 40% synchronous instruction and 60 to 70% asynchronous instruction. And I'm going to tell you a little bit more about what that means. So looking at this slide, looking at the asynchronous slide first. So asynchronous instruction means that students can complete it at their own pace on their own time. This is where our direct instruction will happen. On Zoom lately, we know that if the doorbell rings, if the dog barks, if your baby sister starts crying, you miss what happens and you can't go back to it. But when our explicit learning, our direct instruction is recorded, students have complete control over their own access to learning. So if they need to watch that direct instruction 3 times before they're able to tackle that on their own, they have the freedom to do that. They also can show it to a caretaker and have that parent or older sibling watch the same instruction and then support them in that learning. That asynchronous time will also involve independent practice opportunities. And then when we look over to the synchronous side of the slide, that's live instruction at the same time. So that's when students are with a teacher remotely, and that's where they'll have time to interact with the learning that they did asynchronously. So they're able to talk about the discoveries that they made, some struggles that they may have had. They're able to have lots of time to talk and interact with peers, with teachers, and get feedback. That synchronous learning time will involve a morning meeting, a strong focus on social emotional learning and a classroom culture, peer relationships and interactions, time for a read aloud, and then small group time for small group math instruction, small group reading instruction, and then any interventions or services that students might need based on their individual needs. The high school model looks a little bit different because we know that high schools have a lot more going on. So I want to specifically address what the provision of this program will be in high schools. The majority Canvas remote learning course courses and choose Edgenuity courseware, have access to the NC different than the other Edgenuity courseware. With those two options, those are not provided by CMS teachers. Those are provided by teachers through those programs, and there is a cost involved. We currently utilize those courses when there's a need that can't be provided at a school, and we can continue to do that as we move forward in the full remote academy. And the table in high school is students are able to attain credit by demonstrated mastery. So they would work with their counselor in order to apply for this credit, complete a test, and then complete a project or some kind of work that demonstrates mastery for learning that they may already have expertise or have done some independent learning in. So that is the high school program, and I will hand the microphone back over to Dr. Barnes.
Thank you, Kim. So staffing for the full remote academy. As Ms. King said, we'll be staffing with primarily CMS teachers. In the instance, in this particular example, if you had 120 students who were already enrolled and registered for the full remote academy, you would have approximately 6 teachers who would be assigned to them. The staffing allocation to the academy on a school-by-school basis will be based on the number of students who register for this option. It will be based on the number of students who register for this option. There will be, in some instances, where there might be a relatively small number of students who register at a particular school in a particular grade level. In those instances, students would still be able to take advantage of this option should their families choose to do so. In that instance, we'd create what you might call a virtual classroom across schools, and centrally, we would support those principals and those schools to be able to make sure that families who choose this option could still avail themselves of it. I want to continue to enforce something that Ms. King has continued to say, which is whether if a student has an exceptionality and needs those services, if they need ESL services, or if they're a talent development, TD, and they're eligible for those services, they can still receive that type of service in the full remote academy. They should not feel that this is prohibited to them. It is not. It's available. So how does a family register for the academy? Families will be able to register for the full remote academy right on our CMS website. There'll be a very short registration form which they can fill out electronically. Right now, that registration has been translated into 5 different languages, and on our website, our instructions will be able to be read in multiple languages. We're going to aggressively promote this option through both all of our CMS social media sites, media community, and partner with our other community partners to be able to intend communicate with them about this option. Plan B, or to our community, and they want to for that full day at 11:59 p.m. On Thursday, the 23rd, we will have a virtual answer community questions about the academy, and we'll offer that at multiple times. For those families who come to us to enroll their students after the window closes, we'll have a rolling registration process. So if a family comes on the first day of school to enroll in Charlotte Mecklenburg Schools, once they basis, but we have a preliminary registration period for those families who have students currently enrolled. With that, I want to do 2 things. First, I would like to publicly commend Ms. King and our colleague Akeisha Craven-Howell, who through their joint leadership with both school-based and central office staff have stood up this option for our community. And second, we both like to be able to take any questions that you might have.
All right, and before we go to questions, I will do a quick time check. But this is important that we fully flush out this opportunity and that our community, we need to make our community fully aware of this opportunity. And I'm excited to do some sort of a virtual roadshow to get the word out while registration is open. But let's also do a time check, just that it is almost 6 o'clock, and we do have some more guests here who are some additional medical experts who've made time to be with us and answer our questions. We were hoping to get to them at 6, and we have a couple more agenda items, so let's just be quick with our questions. Ms. Shipp?
I have a quick question, too. You mentioned EC. What will that look like specifically in terms of services such as PT, OT, I'm saying, physical therapy, occupational therapy, and then in a remote setting?
That's a very good question. Our EC team has been working around the clock in order to prepare to be able to classes, metro classes, self-contained classes. So there will be provisions for that. And as students register, we're able to continuously evaluate the registrations so that we can continue to develop plans based on student-specific needs. Two things that I can share are that depending on a student's L plan or TD plan or IEP, it may be more appropriate for a teacher to co-teach and actually be part of that synchronous learning. And it also might be more appropriate for the teachers to plan together and for there to be enhancements or adjustments to some of the asynchronous learning. So it will depend on the student's specific needs.
Okay, and you mentioned Metro. I just want to say real quick, is Metro, how's that going to look? Is that a standalone situation?
Yes, that will be a standalone situation designed to meet student-specific needs.
Thank you. Thank you all very much.
Ms. Sawyer?
What technologies will students be provisioned with when they participate in this?
Just like all of our students in CMS, our K-2 students will be provisioned with an iPad, and our 3rd through 12th grade students will be provisioned with a Chromebook.
Thank you. Ms. Marshall?
I actually had some experience homeschooling some years back, one of my daughters, and when you are tasked with doing this, you're pulling everything together yourself. In this situation, tell me what a parent might have to pull together. What would be provided? I understand technology would be provided. What else would be provided by us, by CMS?
That's a great question. So all of the instructional content is provided, and it's provided at a developmentally appropriate way. So as the parent of a kindergartner, that really matters. You need to have instruction provided in a way that will engage your child so that you are not needing to sit there and police your child the entire time they're trying to learn. So that will be accounted for. We are working to make sure that work is developmentally appropriate, and we know that doesn't mean 6 hours of being on a computer a day. And so we are in discussions about how we can ensure that all students have notebooks and pencils and crayons and scissors, what they need in order to be successful in their work.
Okay, thank you.
Mr. Schul?
So just first a clarifying question on the K-8 Academy. What is all block direct instruction?
All block is part of our L education curriculum adoption in literacy kindergarten through 8th grade. In kindergarten through 2nd grade, students have a skills block, which targets early literacy skills. And then after that, 3rd through 5th grade, it's considered an all block, and it moves on to more of a comprehension focus.
Okay, so we're changing the typical array of dividing things up between subjects?
These are pieces of the curriculum that are built in. This is what the model looked like last year. Something that is a little bit different is that we'll have grades that did not, the curriculum expanded this year. So, but this is, we are working with L Education to ensure that we are delivering this in the most appropriate way, given our constraints across all models.
Okay. And then on high school, what's the asynchronous K through 8, but I didn't see it on the high school.
Best practice recommendations is still to maintain a 30 to 40% focus on synchronous learning.
Okay. And then I read on the high school part, and I had a bit of a scary thought when I read the CMS teacher can be used for both the fully remote and the hybrid models. So to be clear, are we tasking teachers with developing curriculum for the online academy and their in-person instruction?
The academics team is working with master teachers this summer to build out full courses as much as possible so that that burden will not be placed on teachers. PLCs will work together to develop some of the shells a little bit more, but the effort where teachers are used across both modalities, it will be done in a way that allows that to happen. We know that people can't actually be 2 to 3 places at once.
Okay. And my last question was, for the asynchronous learning in both cases, are teachers still going to be available during asynchronous learning for questions, like via email or Remind or whatever it may be?
Sorry, will teachers still be available during the asynchronous learning times?
Right.
Yes. So while students are working asynchronously, that's time that teachers will be pulling small groups, so they might not be available at a moment's notice. Because of that, they will still be doing some instruction. But a big lift on the teacher's part will be to give really thorough feedback on the work that is completed during the asynchronous time.
Okay, thank you.
You're welcome.
Mr. Chair, can I add one thing also that we forgot to reinforce, is that when a student registers for the Remote Learning Academy, they're still based at their home school or the magnet upon which they're enrolled. They're not leaving or surrendering the seat at their school. This is an option at their school. They're not leaving. So if mid-year they decided they would like face-to-face, if that's what we're in as a district, they could then make that choice and they would still have a seat at that school.
Okay, Dr. Jones, and then Ms. Byers-Bailey, and then Ms. Cheek.
What you just clarified is what I was asking for, particularly because we have the virtual high school, and I wanted that elaboration that you just gave. Thank you.
My question is regarding staffing. We have, I think it's over. All right. We have some teachers that may be reluctant to come back to the classroom setting because of their health conditions or the health conditions in their family. Can teachers opt into this only and not be requested to come to a live classroom?
Ms. Barber, thank you. That's an excellent question. What our human resources team has already done is canvassed our staff to ask which individuals may have pre-existing conditions or have concerns about returning to the classroom. In their review of those self-assessments and acknowledgments by teachers, they are sending to the principals, here are those who have both requested and have been awarded an alternative service opportunity. Those teachers would be prioritized to be able to teach in the Remote Learning Academy so that we can leverage their skills and gifts, even if they cannot return to a brick and
I'm getting a lot of comments from people at home that they cannot understand a word that's being said at the meeting tonight. So I had a negative COVID test yesterday, and I'm not going to breathe on anybody, so don't get in my space. So how long do students need to stay enrolled? Quarterly, or can they switch at the semester break?
They will be able to switch at the semester break.
That was a big one. And then the other one, if I can I had a parent that asked me about this, and I explained to her the asynchronous and synchronous, the 30 to 40, and she said, what does that mean? We need to make sure that parents understand what that means. They didn't understand that that meant live teaching or taped accessible. So we need to talk to parents in parents' language. Common thing that we do in education is we get very pedagogical and you guys forget that parents have no clue what that means. So can we customize our communication pieces to make sure that parents do understand what they're doing?
Yes.
Thank you.
Would you like me to clarify that one more time now, or?
Well, I want to make sure parents understand that synchronous means live teacher will be right there and they'll be interacting live with the teacher, and that asynchronous means it would be taped and available for use maybe after the parent got home from work or after they made dinner, and they could sit down together and work on their work later in the day. Is that correct?
That's exactly right. The asynchronous time is also independent practice. So that may be going on a scavenger hunt to find shapes around your house. It's not necessarily your child sitting still in front of a computer. It's also reading, the academic reading and the personal choice reading every day.
I'm very anxious for us to mark a great opportunity. Our sister county Wake that beats us at a whole lot of stuff. Has way ahead of the game on us in this. They're tweeting about it. They already announced that Virtual Academy with them. So I want to make sure that that's looking at options right now. And this is an option that would sway a lot of people that are considering homeschooling. We can't afford as a district to lose 10% of our student body to homeschooling when we have this incredible option available for them. They just need to hear about it.
All right, anybody else?
Distribute those throughout the community possibly. Will we be able for the remote?
Thank you.
Occurred to me about the actual internet.
1,000 additional hotspots from philanthropic efforts in the city. Hotspots, we have distributed on those, and they will run out at the end of October unless to extend that. The 4,500 that we have not yet, we press pause on those, and we will get 6 more months of service out of those once. Sure.
And then I was thinking about there's the virtual class option, or the a situation where a CMS teacher might be able to offer the course that would have the option to go with the VPS, the virtual public school option, is at the same time for just one course. I just want to clarify that.
If a course is offered by a CMS school and teacher, the student would not have access to NCVPS and NCVPS course.
So it would really just be, and will students be able to and be taught by one particular teacher? Is there an opportunity for that if you have, 10 students at any high school and 10 at another to pull them together?
Yes, that is an opportunity we are looking at, and we'll be able to, as students enroll and we see what the needs are, we'll be able to delve into what that needs to look like.
Anyone else? All right, so a couple of questions for me. particularly at the high school level, but even at the middle school level, it sounds like a lot of different kinds of courses to choose from. So when a student and his or her family are registering for this, do they work with their counselor to navigate through?
So the schools will be working with students to facilitate that the best that is possible. It is possible that by opting into this academy, it may not look 100% identical, but we are going to do our very best and work with schools to ensure that we are able to offer students every option possible. And then, as Ms. De La Hara referenced, like, we do have some other options where necessary in order to provide some flexibility.
But what I mean is, I'm picturing my 12th grader. How does he know? How does he know, A, like, okay, here are all these cool Edgenuity classes, here are all these cool NCVS classes, what do I do students need to make an appointment with their counselor to kind of go through this process, or is there going to be a menu where they can just click, 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 or?
This last spring, just as part of our normal course of business, students completed course cards to be able to select courses. As they were doing so, principals and their administrative teams are creating schedules for each student. The same practice would apply to students, that they would just take those in the academy. Okay. So if a student, for example, had chosen their courses and they needed a science and they chose physics, as opposed to go to that physics section in the brick and mortar building, if that was something we were offering students at the time, they would take that physics course at the remote academy instead. So they would not have to repeat that process of asking for courses. We would utilize what they already provided their counselors. And as any practice, whether they're in a brick and mortar building or remote, we want to make sure that they're aligning courses that they need and would be credible for either their postgraduate aspirations or for their on-time graduation.
Well, can we use this as an opportunity to increase access to higher level coursework that with an eye towards equity for schools that we're working towards, the bottom line is we have schools that just don't have as many options for AP classes and higher level classes as some of our other schools.
I think this can be certainly an opportunity, and to do that, this might be a way. Students should follow the same process that they would follow if they were in a brick and mortar building, that change their schedule once it's established, and that way we could slot them into what's available, whether it was available in Canvas, whether it had to be taken in Edgenuity, or had to be taken in a North Carolina virtual public school course.
Well, I'd like to see us be very intentional about that. I think we are all giving up so much and losing so much because of this. Let's push really when students were signing up for Ms. Ship.
Yeah, I just want, because that has been a challenge, especially with IB courses.
Before we wrap But let me just make one more to our families who are listening in. If you go in at your own, master teachers who help develop, still have the support child school. You have your counselors and your school psychologists. You have to go it alone. So I really want people to yeah, do we, we will move on to the next portion of the agenda. So thank you.
kindergarten through grade 2, and all of our students in grades 3 through 12 will have Chromebooks issued to them. We have all of our new devices on target to be delivered to our district in early August, and we can begin provisioning them even before August 17th, which is the first day of school. We do have a learning management system, which I like to use as the Chief Academic Officer. I refer to it as the mothership. It's the home base where all of our families, our teachers, our students will continue to go to access their curriculum, their learning, their lesson plans, even our professional development. We are using this learning management system across all of our grades pre-K through 12. I do need to mention that we are not one-to-one in our pre-K classrooms, but we have an aspiration to identify a means to get there. It's important to note that. But we have already begun doing the heavy lifting of migrating all of our curriculum resources that are pre-K related into this digital environment. What's important for us as a system and as a community is to continue to learn, some instances unlearn, thinking about new terminology that we are introducing to our parents, our students, our teachers. We know that virtual learning will continue to be a component that exists both in our homes, in our classrooms, really everywhere. Virtual learning just encompasses us using a device and the internet, and that happens in many instances. But we recognize that as we're thinking about these various options, remote learning will require us to promote learning opportunities where the teacher is not physically present in person with the children. In other instances, in various models that are a part of this remote plan, we will have in-person learning, which will have our students being in our brick and mortar facilities, in person with our teachers. And many of you have educated me that's an in-school learning experience, and I appreciate you helping me understand what that means. In order to do this well and do it equitably across all of our schools and for all 149,000 of our students, we need to make sure that all of the resources that we have invested in over the last few years are available seamlessly, both in person and remotely. We cannot compromise quality, and we need to make sure that access and flexibility remains a key standard. All of our most recent curriculum investments for English language arts and mathematics, I need to take a deep breath, will be available to all of our teachers, our students, and our parents, both remotely and in person via our various technologies. And this will allow us to have seamless integration as parents change and make various choices on behalf of the well-being of their families. If they choose a full remote academy option and they choose to integrate back into our brick and mortar facilities when they choose that it's safe for them to do so, we're going to integrate seamlessly because the curriculum and the resources and the offerings that we have are all on the same track. And we are all using these same resources as a guaranteed viable curriculum, and all means all. It's important to note as we're promoting this plan, the equitable instructional practices and supporting unfinished instruction, knowing how the end of the year took place after March 13th, it continues to be a driver of this work. We want to make sure that we continue to respect and honor the authorship and the artistry of our teachers while continuing to provision a basic standard floor of excellence in terms of resources so our teachers have the ability to do this incredibly complex job that they're being charged to do, but also understand that we are not dictating how they do that. There needs to be a space for all of our teachers to be able to personalize those experiences, and we're doing that in a very consistent way through our learning management system where we are building in partnership with our teachers, not to our teachers. We're building various courses, shells, and templates to support the 400 plus courses that are available in our district. In the year ahead, we have prioritized building Canvas courses that encompass all of our sequencing, parent videos, student exemplars, lesson plans, all of our comprehensive content for all of our core classes in grades kindergarten through 12. There will be a full suite of courses that will await our teachers when they return to our school buildings, or if they don't, we can send it to them via technology for them to be able to build and hit the ground running and not have to spend endless amount of hours identifying where that content lives and how in the world am I going to provision it to their students. That's going to be something that we take off of their plate, and we're building it in partnership with our teachers. Because we have so many course offerings, we can't build, or we do not have a comprehensive curriculum for every one of our 400 courses. In a lot of instances, we rely upon the artistry and the ability and the expertise of our teachers to build that. And so in some instances, we provide a shell which has all of the scope and sequences, our standards, other types of curriculum assets to make sure that we continue to provision high quality instruction. But there's greater flexibility for those teachers to be able to build and pull in other content to be able to personalize that, knowing that that is going to be necessary in order to get the job done. In other instances, we're providing similar templates for courses to ensure that all of our families who are supporting various children in the same home, that they're not going to have to go to various places to access their learning or their lesson plans to help support their children. It's all going to be in one place. The team of learning and teaching team in partnership with the Office of School Performance and our Equity Office have done an incredible job of building a scope and sequence over the next 3 to 5 years to build these types of courses out. This is just the beginning, to make sure that we continue to go deeper in partnership with our teachers and learn more as they're beginning to implement over the course of the next year. It is really important that we are mindful of the universal needs of all children while we are designing what that looks like in a remote environment as well as an in-person environment. And I'm very proud that we are leaning on remote standards to be able to drive and develop these courses. What teachers can count on and expect from us is clear guidance around pacing, exemplars, parent support letters that they may consider using that not just help identify ways that parents can get plugged in and support their children at home, but it can also set up and build enthusiasm and launch new content in new and meaningful ways so we can build having greater conversations in our homes about what our work is, knowing we're incredibly, the role that the parents have in this space as partners in this work that we do is more important now than ever. It's never been unimportant, but it's incredibly important that we're building and giving resources to parents to support their children at home, and this can do that. Our commitment to all learners is what makes this remote learning plan special. It will have built into it various things that accommodate all of our students, but I want to lead in and start by saying this. Regardless of the plan that we choose to implement, attendance matters every day. Learning will begin on day one for all students and for all teachers. We will be flexible in remote environments that while we will continue to take daily attendance through homerooms and daily classroom schedules, especially if they're synchronous environments, there are other creative ways that we have been identified by NCDPI as being exemplary and really thought-provoking and leading in this state about thinking about work, different assessments that will exist in our Canvas platform, that we can think about the work that people are doing, not just the seat time to be able to take attendance. And I think that's really progressive. Something else is that we will continue to build these courses, as I shared, with the opportunity for teachers to personalize them without really removing the consistent experience that families will have and children will have when they're supporting and using these resources at home. We will make sure that through the use of our Canvas platform and these various courses, templates, and shells, that we are continuing to be incredibly mindful of providing the supports and the accommodations and modifications, especially those that are outlined in students' IEPs and 504s. But we are also going to be very clear that we do not begin this year with 9 weeks of intervention. All of our students are going to come back to a standards, grade-level learning experience where we will provision opportunities for teachers to think about how we can provide increased accommodations on how we teach, but we are going to stay incredibly firm, where appropriate in most cases, around what we teach. It's going to be incredibly important to continue to provide a high-quality standards alignment experience moving forward in this environment. For our students who are English language learners, it's important that we embed and not have something like this live separately. All of our instructional tools, providing instructional strategies and digital tools that continue to support those children and families at home while they're increasing their own command of the English language. We know that we're going to have to also provide areas for amplification and enrichment and acceleration for high-achieving students, students who are hungry and eager to do more. And we're provisioning those spaces and those opportunities, as well as listening to our teachers where we may have missed the mark, to continue to enrich families so they're not necessarily waiting upon what lessons they're being provided. They're able to go faster than the course sequencing provisions for them. Under Dr. Hayes' leadership, we have begun communicating directly with our teachers every Sunday night. We have over 10,000 teachers in this district, and every single Sunday evening, we're continuing to engage in them, providing them opportunities to know what professional development is available to them to get plugged in to support this type of learning, regardless of whether it's in person or remote. That is especially important for our kindergarten, first, and second grade teachers who are teaching in a one-to-one environment for the very first time. They have continued to plug in to figure out how they can use those technologies now so they can hit the ground running. And we have begun, this is exciting, so forgive me if I'm exasperated. We have also begun to solicit opportunities for our teachers to build these courses in partnership. And I'm really proud to say that we have done this work, and we're continuing to do so with over 70 teachers that are in our field to make sure that we're holding ourselves accountable to doing what we need, or what they need from us, leading with empathy. Our timeline is clear. We began to launch this entire plan to our principals and executive leaders across the district just over a week ago at our summer leadership conference. We are positioned to begin pre-releasing as a teaser what these lesson plans and templates and courses look like for our teachers in the week ahead. And we are able to be on target right now to fully release the first quarter of all of our Canvas courses, templates, and shells by August 3rd, which positions our teachers in a place where they have a couple of weeks. I wish it was a couple of months, to be honest with you. I wish it was a year. But we're giving them a couple of weeks to immerse themselves in this content if they so choose, to make sure that they feel supported, they know that we hear them, that we listen to them, and we're doing this with them and for them. We will continue to partner with teachers throughout the course of the year. It's not just over the summer. We will continue that partnership and provide contract opportunities for our teachers to build, and we'll begin releasing new curriculum assets over the course of the year, trying to identify a means, staying ahead of the curve, and hopefully accelerate this work as we continue to bring more people into this space. And so, Mr. Superintendent, I'd like to turn this back over to you for your consideration with the board this evening. We're very proud of our remote instruction plan, and if there are any questions at this time, I'm happy to entertain those. Thank you.
Thank you, Mr. Kingsley. Thank you, Mr. Kingsley.
And of our guests who've come to present, so let's be crisp. All right, Ms. Marshall.
Thank you, Mr. Kingsley. And I do want to reiterate for everybody that's watching us, we, as well as the other 114 school districts in this state, are obligated to submit a remote learning plan by July 20th. This is something that we know we're going to access regardless of what is tonight, whether that's for our virtual school, whether that's if we're all virtual, whether that's if we are in a plan B. So this, just to know that this is something that is supporting all our work, but this is a statutory requirement. So this is why we're going to vote on this tonight. I just want to make sure as we start our questions. I always like to know sort of what it looks like on the ground. And I'm going to put you on the spot a little bit and ask you, let's just, for example, talk about, say, a sixth grade class, whether that's English language arts for sixth grade, what that might look like for a family, a student, as they engage with this material.
Yes, ma'am. Thank you for that thoughtful question. So as we know that our sixth grade students this past year began to utilize our new English language arts curriculum, EL education, we have begun to work with EL education in digitizing all of those curricula. And we have also been deeply investing in digitizing the trade books that our teachers and students have, so they will be available to them not just in a print form, we have them for every student, but we're also beginning to have them available in all of our Chromebooks and our iPads. So I think that's important to note. So the access is going to be incredible, so we're not relying upon people to continue to come back in for a new series of books. As I mentioned, Canvas is our learning management system, so all of our lesson plans, our assignments, where teachers will provide feedback, where parents can have an opportunity to evaluate and monitor what children are doing or at home, will be completely built into that space. If I'm an English language arts teacher in sixth grade, the ground floor of what all of that looks like is already being just given to you in a digital environment. We're just asking you to consider utilizing it. We're asking you to utilize it, and to be clear. But we're also asking you to personalize it, to build authorship, to recognize that you have the ability to make accommodations on top of that. But in terms of what that core center experience is, it's available in their technologies and in the different various tools that we have in the system.
Okay, thank you.
You're welcome.
Ms. Shipp.
First, I want to thank you for looking at this plan as way we started back in March and looking at what we have now. This is definitely very rigorous. It is exactly the kind of plan we want to see when we talk about remote learning. And I want to commend you for that and the work that everyone has done. And one of the most important things is always empowering teachers. To see that you had 72 teachers involved and staff involved in this is tremendous, because they are the ones that want to always feel like that they have an input because they're going to be doing the teaching. So I want to thank you for that. The question I want to ask is about consistency across the district, because I think some of that was questioned with remote learning early on. Some schools were doing it one way, other schools were doing it another way. So I know you talked about having the Canvas and having the platform, but you said teachers can also add some of their own personal things to it. So how do you see that in terms of keeping that sense of consistency? This is a great program over here, and this school is doing great things with remote learning. How do we make sure that's going across the district?
Yeah, it's a great question. Since March 13th, the resources that I'm sharing with you this evening were not in place when we had to close our schools. So we have turned our learning and teaching division into a publishing company over the last few months, and they've been working over 20 hours a day, honestly, to ensure that these resources, regardless of whatever plan that our district is in and whatever option a family may choose because it's in their best interest, that we do not compromise on quality, we do not compromise on access, and we do not compromise on standards alignment. Every one of our 10,000 teachers in this district have millions upon millions of discretionary spaces and moves that they make as professionals and as experts to continue to enhance and adapt curriculum, how they interact with students in small groups, in whole groups, how they begin to engage in relationships and understand what they're happening. We will never take that authorship and expert artistry away from any of our teachers. It only enhances the experience. But in the absence of this high quality curriculum, what we have learned over the last 2 years is that our teachers have had to create it on their own. And in many cases, they've been spending 7 to 10 hours a week just identifying the content, while they could be spending that time on how they can personalize their learning for their students. We have provisioned them that time back and have given them the space to continue to be the authors of what their learning experience is in their classroom, whether it's remote or in person. That's something we should be all very proud of.
And the other thing I want to add, and I want to make sure that we're monitoring this because I think this is so important, is how we look at attendance. This is school, and kids must be engaged in the work. So looking at attendance, looking at grading, looking at assessments, and making sure that that is adhered to appropriately, and especially as we talk about coming back to school, if it's in remote, however they come back, and we talk about these assessments that we do at the beginning of the year, making sure that we have those efficiently and that everybody's on point and that they understand the seriousness of we are in school, even in the remote learning sequence.
Yes, ma'am. One of the benefits of Canvas is that it provides us weekly, even if daily, data on what students are engaged in completing assignments and which ones are not. Our principals will have access to 5-day reports to be able to know whether children are leaning in or for some reason they're not able to just yet, which allows us to engage in their families and access to various other supports that are available to in this district to invest and begin to identify what we can do to better support children at home, to get them more involved and ensure that their engagement becomes more authentic. Without having this learning management system, we simply would not be able to do that.
And the parents, will Power School be used in the way it has been used? Will we have that set up?
Yes, we still are required to provide and take daily attendance in Power School, but having Canvas allows us to not just use the physical presence. It allows us to use their assignments, their engagement, their enrollment in different assessments. So all of this various data we can also use as a form of our attendance, which our current CMS Virtual High School has been doing for quite some time with a lot of success.
Thank you
You're
so
welcome.
much.
Ms. Byers-Bailey. Mike.
I wanted to follow up on what Ms. Shipp was talking about in terms of students being engaged. Very often we have students at home with the technology, but the parents are at work and maybe a sibling is helping or a babysitter is helping. And that may or may not be as robust. What are we doing to support, what would our support be for that family?
So lots of things, right? So the outreach from our teachers to our student families, trying to identify how we can best support and what we can do differently is always the first line of defense. But in addition to that, we can conduct home visits. We can engage other partners, both internally and externally, whether it's ASEP programs, YMCA programs, to try to identify other creative ways to engage families in opportunities to continue to support children, whether they're remote or at home. This is not going to be easy. And don't mistake my joy and enthusiasm to oversimplify the complexity of this work and what our teachers will have to do. But it's going to take a true partnership and a community effort to do this together, to engage each other in meaningful ways, and I believe that we can do this.
Okay, thank you.
Before I go to the next question, I'm just going to take a moment of privilege to reiterate that, because what you just said is so important. So for any learning that happens remotely, we need to be very mindful as a community that not every student is going to have the same level of family support. And we've got to tackle that together as a community. We need to be very intentional and very creative and put a lot of effort into that. There's a generation of children that are counting on us to rise to the occasion.
Thank you.
Mr. Schul?
So first, I just was wondering if we were going to have any flexibilities or changes in the way that we do grading, just because it seems to me that if a student leading up to a test has had all remote learning versus a student who is in a group that had all in-person learning in the time directly leading to a test, if there's significant differences in those scores, that maybe there should be some sort of appeal process or flexibility there?
Yeah, so that's a great question, because obviously that was a change that was unexpected for many of our students, teachers, and families post March 13th as directed by our State Board of Education. Under this remote instruction plan, it allows us to continue to utilize our existing CMS policy for grading across all of these plans. And what I would share with you is that has been very successful in our CMS Virtual High School for a very long time. And we will continue to go back to what our students have expected of us, what our parents have expected of us in terms of how we provide opportunities for grades, how we provide opportunities for tests, quizzes, and assessments, classwork, and homework. And we will continue to do that how we did prior to March 13th in this new plan.
Right, but my issue is specifically not in a case where we have an all-remote setting as with the virtual high school, but in a setting in which we have two scenarios of students who were learning remotely versus students who were learning in person. But regardless, my next question was going to be about the attendance. You mentioned that there was going to be some flexibilities or other creative ways in attendance. Could you just maybe elaborate a little bit?
Yeah, so as we mentioned earlier, in a remote environment, we will be provisioning about 30 to 40% of the instructional day would be synchronous, ideally. What we are not going to do, while we will be taking personal attendance and who is available, we also know that we have to be incredibly flexible. Because we were available doesn't necessarily translate to our families being available at home during those particular times. So there are other ways, Gabe, that our teachers can take student attendance, completion of assignments, completion of assessments, engagement daily, weekly in our Canvas platform. All of these other various data can be used for attendance purposes, and they are a part of this plan for consideration. And with the feedback that we've received from NCDPI was incredibly thoughtful and responsive to our families in this environment.
Okay. And then I was wondering about what determines whether a course has a shell, template, or a full course.
The biggest difference between a course and a shell at this time is what we have as a comprehensive curriculum that we were able to provision at the district level. So we have just invested in deeply a new English language arts curriculum in grades kindergarten through 8th grade. We have invested recently in new math curriculum in grades kindergarten through 8th grade. All of those will be a part of our courses. Over the last 5 to 7 years, we have invested in science curricula, so we're able to build those comprehensive courses. Areas where we may not be able to build a course but have a template or a shell is areas like some of our social studies classes that we're continuing to may not invest in a comprehensive curriculum that we have distributed to all of our teachers, but we are working in partnership with our teachers to build that. So we're not embedding a comprehensive curriculum for all of our social studies teachers in certain areas. So that's the big difference. But some of the other things that are necessary across the board, student exemplars, parent letters, pacing guides, scope and sequences, that is a constant across all of those things.
So then that would lead me to think that if we have a difference between teachers who are teaching shell courses or template courses versus a teacher who has been given, lucky enough it seems, to have a full course, and there's a difference in the workload between a teacher who has a full course versus a shell template course.
Without question. As I shared with everybody earlier, our teachers in our core areas that did not have an English language arts curriculum were spending 7 to 10 hours weekly building that on their own. There are still many, many teachers in this district that are doing that, and it's important to note, and I appreciate you lifting that up.
Okay, and it seems to me that those might be concentrated in like fine arts or social studies.
Yeah, they become more unique courses, especially in our high schools where there's much more unique course offerings, but we're pretty set in our elementary and middle schools.
Okay, thank you.
You're welcome.
Ms. De La Hara.
And just to clarify, earlier we mentioned the 72 teachers who were hired over the summer to do to help build. So I would assume that most of those were social studies or fine arts.
Yes.
That have already been setting this up. So that first quarter is complete.
Yes, that's a great point. Thank you.
Okay, all right. I just wanted to clarify that. You talked about the flexibility of the synchronous time. If a child can't participate in the class, will it be recorded so that they could watch it later? Is that the way that would work, like they do with the virtual public school?
Yes, and in other instances where we're building courses, we have teachers across the district that are videotaping other lessons, so we're provisioning other opportunities. If it's not the core teacher at the school, we're also able to support that with other teachers and build and drop that into these courses as well to help enhance that. But yes, they would be recorded and accessible at other times.
Okay, great. And I appreciate the comments that Ms. Dashu made about the call for the community and thinking about how we're going to partner. I'm thinking about the parental support and really the teacher support for our foreign language speaking families. If they're trying to communicate with mom and dad, in addition to community support, will we have interpreters available to help support teachers who may be having a hard time communicating with families? Can
Yes,
you talk to that?
Yes, we will have interpreters, we can have home visits, outreach, and the attendance that we've had even in our summer programming for newcomers has been absolutely tremendous as a result of that outreach. So if you are one of those families that are listening in tonight, we certainly want to continue to engage you in new and meaningful ways to make sure that this is a fruitful experience for you, whether it's at home or in your school.
Okay, thank you.
You're welcome.
Ms. Byers-Bailey. Mike.
Thank you for another opportunity to ask a question on this. I was talking with one of my principals of one of my schools that has a substantial ESL student body, and he was bragging on how many of his students had graduated out of that program and were now successfully receiving their academics in English. And then I was talking to another one of my principals, a couple of them actually, on the high school level, who said that they're getting students that are coming into high school having not only no English, but may have had no formal education in their native language, and they're trying to go K-12 in a couple of years and get them functional. how does this program address those high schoolers?
Well, it starts with leading with empathy and compassion. And I think how we acclimate our new families to this district is really exemplary in not just identifying what academic needs are, but we're asking what the family needs are so we can put wraparound supports to those families. I think that's really, really important to understand what was traditionally available at our Smith Center is now being available by appointments to ensure that we continue to provide those supports to our families in new and meaningful ways. But it's not going to be easy. I mean, those circumstances, children walk through our doors every single day, and it's what makes our schools diverse and what makes our country and this community great. And regardless of wherever they are, as public educators, we're going to teach them really well, and we're going to do the best that we can. And so it starts with compassion, it starts with empathy, but it's also not compromising on quality. And the investment in these resources puts these tools in their hands that they wouldn't have had a year ago. And I think that's something for us to be proud of.
Thank you.
You're welcome.
Okay, it is 7 p.m., so let's do a real quick wrap-up. Is anybody else? All right, well then I'm going to turn to Board Member Jennifer De La Hara to make this motion.
Thank you, Madam Chair. I move to approve the remote learning plan as presented and instruct the superintendent to convey the plan to the State Board of Education as required by Senate Bill 704.
Second.
Sorry, who was the second? Okay, we have a motion from Ms. De La Hara, a second from Ms. Sawyer. Do we have any more discussion or debate? All right.
Madam Chair, I just want to clarify for the public, this is not a vote on how we will proceed. This is our remote learning plan that we have to submit to the state that we are approving as a board. And we will have a discussion later as to how we will proceed in terms of our plans within the district.
Exactly. This is sort of a housekeeping vote of the thing that we're required to do with the state. All righty. So I'm going to go ahead and call for the vote. All in favor of the motion, please let it be known by a show of hands. And I'm going to take a moment to count because it's hard to see. All right. That looks like 9 of us. Any opposed? Just to be sure. Okay, Madam Clerk, that passes by a vote of 9-0.
Thank you for your continued support.
Thank you, Mr. Kingsley. All right. Now, this is the vote that everybody is tuned in, the action item that everybody is tuned in and waiting for. The second item that we're voting on tonight is approval of the 2020-2021 school reopening plan. Before the board acts, I turn to the superintendent to introduce this item and presentation.
Thank you, Madam Chair. And thank you, Mr. Kingsley, for that report. A lot of hard work by staff. Tonight, we meet the evening after Governor Cooper announced his decision that all schools in North Carolina should open for the upcoming school year under Plan B, or if conditions locally warrant, choose to implement the more restrictive Plan C. Before we report on and answer board members' questions on CMS's plan for a return to school, we thought it would be appropriate, in view of the serious questions in front of you, board members, to invite some of our long-standing partners to share perspectives. These are partners on the front lines of our local efforts to battle the COVID-19 pandemic. Healthcare providers who can answer some of the most important questions that must be addressed in determining which plan will enable CMS to provide educational opportunity for all students while protecting the health of our students, our staff, our families. We have with us Dr. Gary Little, Chief Medical Officer of Atrium Health, and Dr. Jerome Williams from Novant Health. Now, after brief remarks, these doctors will take a few questions, and I want to thank both Dr. Little and Dr. Williams for joining us tonight, and I want to thank you for your patience and your leadership in our community.
And while the doctors are approaching the podium, I just want to thank them again for making the time to be with us and for the partnership, because truly to navigate through a pandemic, we have to work together across sectors, and that is what has been happening really ever since February. I know our superintendent has had multiple calls per week with team members from your organizations. We were very fortunate to have had Gibby Harris join us at the beginning of the meeting. Because of some scheduling conflicts, we couldn't get everybody here at the same time, and so that's why we had questions with Gibby at the beginning, and now we have you gentlemen here. So thank you.
Sure. Well, it's my pleasure to be here this evening, Madam Chairman, members of the board. My name is Dr. Gary Little. As stated, I work for Atrium Health. I'm going to try to keep my remarks brief. I know time is definitely of the essence. I'd like to just kind of walk you through our experience since this pandemic started and hopefully draw some parallels between the challenges we face, what we've learned, and what the future looks like. 'Cause I think there are a lot of parallels between what we do as a healthcare system and what you all do as a school system. So just to start, I think, and I see evidence of this here today and everything that I'm hearing from the remarks and the questions that the board has already expressed, but I think this is one of the most important decisions you have in front of you, probably in the last 20 years. When this pandemic started, we knew that this was going to be big. And I think one of the underlying principles that we had was no matter what decisions we made, we needed to make them with the safety of our patients and our teammates at the forefront. So every decision we've made since day one and every decision we make now is with that primary focus. The other thing that we sort of acceded to is that we are still learning about this virus. This virus is only 7 months old. And so our experience and what we know now, even from January, is exponential. And so the next 6 months will be the same. We will learn, and we are, as we say in our meetings, we are often building the plane as we're flying it because we're learning. And so I think it's important for you all to understand that where you start today is not where you will be in a few months. I think it's also important that you understand that you will make decisions today, next month, next week, that you will have to reassess and be flexible and change. And you cannot be afraid to change course once you get information. Communication is going to be huge. And that communication must be based on honesty and transparency and clarity. And you need to communicate to all your stakeholders. That will be your parents, your students, board members, community members. Everyone who has a stake needs to have communication about what is going on and what you're doing. You need to have good information about what are your ultimate outcomes that you're looking for. And how are you monitoring that on a daily basis? What are the things that you will look at, as we call it, a dashboard? What is that dashboard? What's the dashboard at the teacher level, at the parent level? What is at the school district level, the board level? All of you need to agree on what those outcomes are and how you're going to track them going forward. Some of the challenges that we faced as we started to face this pandemic was we needed to gain some control early on because we didn't really know what we were facing. We had to prepare plans. We needed to stockpile PPE or protective equipment because we didn't really know where and how fast the virus was going to spread, and we needed to really get control of it. So one of the things we had to do was focus. We stopped, as well as our colleagues from Novant, we stopped doing elective procedures because we needed to be prepared for an onslaught of patients. We needed to get ready for what was going to happen or what we thought was going to happen. So part of you will have to decide is, what do you stop doing to focus on the response to this? Doesn't mean you stop doing it forever, but you're going to have to focus in. It's all hands on deck. And so the success that we've had is really because we focused as a team. That means everybody from the executive leadership team to our doctors, our nurses, our environmental services, everybody had to chip in and do their part. Some of the other decisions we had to make that were difficult was restricting visitors. In healthcare, we understand how the family and friends of that patient are so important to their healing. They're there for support, whether that's physical support, emotional support. So, whatever it is, we know that's an important piece of that patient's healing. But again, in order to gain control of the situation, to minimize risk, we had to restrict visitors. So we went to very strict visitor restrictions where we really almost didn't let any visitors in except for in very special circumstances. Now, over time, we've been able to relax some of these things, but it was very important for us, again, to minimize that risk and keep our patients and our teammates safe. We had to make sure we had the environmental controls. So physical distancing, setting up your rooms, your classrooms, whatever they may be, so that you can only be a minimum of 6 feet apart. Putting up shields where you can protect your teachers or other staff members from respiratory secretions. Removing some chairs and tables, all those kinds of things that you will need to look at from an environment standpoint to make it as safe as possible, to force your people to physically distance from one another. We went to universal masking early on. That means everyone who enters our building has to wear a mask, unless they either physically cannot wear a mask or there's some other developmental issue that prevents them from being able to wear a mask. We do screening at all entry sites to our buildings. We check for symptoms, we check for temperature, and we do that on everyone who comes in, whether that's a patient, a visitor, our staff, a vendor that needs to come into our buildings. We do that every day on every patient. That's in our hospitals as well as our doctors' offices as well. We have to put in processes of how you're going to respond when one of your students or your teachers does get an infection, because it's inevitable. What you're doing is trying to minimize risk. You cannot eliminate risk. You can only minimize risk. So you have to then have robust, really clear set out plans of how you're going to respond when an infection happens, because it will happen. And so how do you, one, detect it? How do you then communicate that to the people who it needs to be communicated to? How do you track down who they've had contact with and get them tested? So all those things, you're going to have really robust plans for when the inevitable does happen. I mentioned data already. I mentioned communication. Those are the things that I think will be important as you guys go along. This is, again, an unprecedented situation. This virus is unique in that, in most cases, when we see these types of viruses, we can use symptoms as the point when that person became infectious. With this virus, unfortunately, people are able to shed and spread the virus either before they become symptomatic, or they may never express symptoms, but they're still infectious. And that makes this virus extremely challenging to face. The other thing, I think, that a challenge that you're going to face is you're going to put all these controls within the confines of your schools, but you can't control what happens once they leave the school. And our experience is, when our teammates do get an infection, it's typically what they're getting at home, or they let their guard down amongst their coworkers. So in the break rooms and things on the way to and from work, in the garage and things like that. So you have to continually remind people to continue to do these measures, to not let their guard down, even though they want to. And I'll conclude my comments with, even with all of this, remember, this is a marathon, not a sprint. This is going to be a prolonged response that we're facing. And I think one of the things that I cannot measure, but is the thing that most keeps me up at night, is the mental health of my team and the stress and anxiety levels that they're facing having to deal with this, coming to work, worrying about their home life, their kids, their children, their parents, and other loved ones that they may be caring for away from work. I can't put that in a chart, but I have to have a way to help people deal with the stress of dealing with this pandemic. And that's something that you're going to have to understand and figure out how to monitor that as well amongst your students, amongst your teachers, amongst all your staff, your parents and families, etc. So that's something that cannot be in a spreadsheet, but it's something that you need to have at the forefront of your thoughts as you deal with this. That concludes my remarks. Thank you.
Thank you.
Thank you, Superintendent Winston. Thank you, Madam Chair. Thank you, CMS Board, for the opportunity to share information and partner with you. As mentioned earlier, my name is Dr. Jerome Williams. I'm Senior Vice President for Consumer Engagement and Corporate Health for Novant Health. I have a team here with me today. Why do I have a team here? Because it is very important that your questions that you have are answered in granular detail. And I'd just like to introduce very quickly my team, Dr. Chuck Berger, who is our Medical Director of Corporate Health, as well as Medical Director for Employee Health. He is responsible, a lot of pressure, Chuck, for 30,000 Novant Health employees, their health and wellness and well-being. I'd like to introduce over to my left, Dr. Catherine Olmstead. She is the Chairman and Chief of Pediatrics for Novant Health. Right next to Catherine, he was sitting right next to her, Dr. David Olmstead, and they're able to sit together because they're husband and wife. Dr. Olmstead is a pediatric cardiologist, and he will share some information about student athletes. We also have Dr. Jason Much, who is part of our emergency services. Mr. Marcus Carnegie, who is our director in our DPS, Digital Products and Services. He is here because he's going to share some information about technological advances that will be able to hopefully assist you in your schools. And then last but not least, Mr. Rocky McGregor. He is our Chief Operating Officer of Consumer Strategy and Products. So why is it important that our corporate health team is here today? Well, what we do in corporate health really is directly work with businesses, schools, and universities to improve the health and wellness of employees and reduce healthcare expenditures. This is pre-COVID. So this is a program, a department that we have ongoing, and we work with many companies and universities for health and wellness services. Since COVID-19 hit in the mid of March, most of our focus has been working with employers to get their employees safely back to work, And Superintendent Winston mentioned earlier the word partnership. And as an anchor institution in this community, Novant Health will be partnering with any and all to safely return employees back to work in our schools, back to our system, to their classrooms. When we partner with institutions, we take it upon ourselves to guide and provide subject matter expertise for all of the activities on your premises. So we talk a lot about students. We talk a lot about teachers. But there's also vendors that come on the property, right? There's construction workers that come on your property. Okay, so you want to make sure that all of your stakeholders are cared for. And so we have a comprehensive toolkit and consultative services that we will share with you if there is an opportunity to share that information with you moving forward. At this point in time, I'd like to have Dr. Berger come forward, and he will share with you some of our COVID-19 return to work services that we're engaged in with some of our universities and some of our independent schools and employers.
Thank you, Joe. Good evening, everyone, and thank you for the opportunity to share some thoughts with you regarding some things we've done at Novant that you may find of a great service to you. So as this began back in March, we identified that we really needed to take care of our community members and people who got sick. Well, how do we do that? We have to keep our team members healthy and keep them safe so that we can care for all of you, everyone in our community. So we developed a bunch of guidelines and protocols to screen our team members to make sure that they're safe. And if they start showing signs of COVID, then we take them out of work. We evaluate them carefully, we get them tested, and we figure out how and when we can get them back to work. So we took this information and we morphed it into something we use in corporate health. So we use the same URL we use internally for all of our team members, and we now use it for a variety of corporate clients throughout the Piedmont. So that lets us screen employees, screen students, screen faculty. We can get them sent for testing if we need to. We communicate with them and their employers about what needs to be done, and we also get them back on the return to work process. So we have a large team of nurses and providers who engage these employees and team members and get them tested, tell them what they need to do, and then if they get sick, we help manage them, help identify what needs to be done so that we can get them back to work in a timely and safe manner. So this is, I think, a tremendous service that we provide, and I'd be happy to take any questions you may have. Thank you. And I believe Marcus is next.
Thank you all. Thank you. I'll be brief in the interest of time. I've heard the term many times, management, and we talk about the term exposure. And what we've done within Novant Health and our digital products and services team is built a platform to manage exposure. We call that platform exposure management, where we're leveraging technology to reduce the risk of exposure and promote a safe environment for employees, students, and visitors. Dr. Berger mentioned pre-screening platform. This pre-screening platform was developed internally for Novant Health workers. We have since taken that pre-screening platform that quickly gets an employee or a student or an individual through a series of CDC questions. There's an algorithm behind those questions based off of those responses. It generates a simple pass or fail. A pass meaning you can return into the school or work environment. A fail meaning, no, you don't have a COVID-19 per se, but we want you to seek consultation from your primary care physician. And that pre-screening platform is delivered via a very light, simple URL. So that was developed internally. We white label that technology and we deliver it to a number of employers, institutes of higher learning, public and private school systems today. In addition, what we've done internally within Novant Health is we're leveraging advanced thermal imaging technology that scans temperature rapidly. So think of coming into an acute facility, and before the evaluation of this technology, we had to have a number of folks on staff with infrared thermal scanning technology to scan every individual visitor and employee coming into the facility. We've since evaluated and have now deploying over 100 of these advanced thermal scanning technologies that within an instant can sense temperature and also can pick up on whether the individual has a mask or not. So if you have a masking protocol, it will tell you you need to wear your mask. It will also tell you very quickly whether you have or under or over a temperature threshold. So these two technologies are examples of how we can reduce exposure. We can manage the environment through technology to rapidly assess before folks come into the work environment via the pre-screening platform, and when they come onto the work or the school campus or the environment via advanced thermal technology. We're also looking at, we mentioned, I've heard the term contact tracing. We're looking at advanced digital contact tracing technology where we can track a person through a particular facility, and if they have been, contracted COVID-19, we can track them and make sure that other folks who have been exposed or potentially been exposed to that person, there's proper surveillance around that individual. So that's also technology that we're constantly evaluating and we're looking to quickly develop and push out within our facilities. And last but not least, we're looking at e-alarm technology, which think of it as wearables, where you can monitor vitals, and those vitals are specific that we're monitoring and looking for specific thresholds. And if that threshold is met for a particular vital, it could mean that you possibly have contracted COVID-19, that you're possibly symptomatic. And so all of these different things are things that we're doing internally within Novant Health, but we've quickly realized the opportunity, right, and the need in our community to take these technologies and push them out so that organizations like Meck County Schools can take advantage of this. So let me pause there, see if there's any questions.
All right, thank you. And go to questions.
I just have one. With that thermal scanner, thermometer that you've got, is that something that is available that we could get?
Yes, so yeah, that's a great
How
question.
can we get that?
That's a great question. So we've evaluated several technology providers, and the key in our evaluation was naturally accuracy, but right behind accuracy was scalability and cost. And so through that evaluation process, we looked at 4 different solution providers, and we landed and zeroed in on one. And we've already worked with that vendor partner on a reseller agreement so that we can then take that same technology, wrap it with our health services, and deliver that to you all.
I would love for you to share that with Carol Stamper, that information, if you could. That would be super helpful. I mean, I know how many nurses or how much staff is coming in at like 6:40, a.m. and p.m. to check in a hospital, and to do it individually is very cumbersome. Not as many kids as we might have coming into high school, but I can understand the need for that to happen because every nurse wants to check in at the same time. So that would be great to hear more about how you're doing that with large amounts of people and what the technology is versus just a single scan.
I mean, absolutely. When you talk about human capital management versus technology, and my mask keeps falling off. I apologize for that. It's a great opportunity to leverage technology to reduce that overhead and improve the accuracy and make the environment safe. So we're happy to
That would be great to share that
information.
Thanks, Marcus.
Thank you.
Ms. Schiff?
Yes. My question was dealing with, I thought it was great that you had a management team, someone who's just working with exposures, management exposure team. Are we going to have something like that in the schools? I think we need something like that. Would we look at that even if we did it by learning communities, but someone who's strictly supporting management of this exposure and the things that are those cases that come up at the school? I think that would be good.
Well, that's what I was referring to earlier about a partnership, okay? This is not you roll out an activity and you just turn your back, okay? Part of the reason that we are engaged in so much technology is because when we engage with our corporate partners, we get feedback. And so when we embarked on thermal scanning or temperature taking, it required a nurse, and if you're a large corporation, it would require a number of nurses, and that can be quite expensive. So we took that feedback and partnered with that particular company and looked for different solutions to reduce the cost. So it's really about a consultative and partnership and a feedback so that we can meet the needs of whatever corporation or school of higher education that we engage in. That's really the key. It's long-term partnership because this is not going away anytime soon. And we have to manage risk, as Dr. Little mentioned earlier. This is about managing risk. This is not about, are we going to have any students or faculty exposed, and then what do we do when that occurs?
Thank you.
We have specific questions we have pediatricians in the audience as well. I suspect there may be some specific questions about the pediatric cohort.
You know I'm going to have questions, so I'm going to let the rest of them speak because to hear the other presenters, I think. Before
Well, I just want to take full advantage of having these experts with us here tonight. So let's just, everybody ask everything that is on your hearts and minds.
Like to hear her speak on pediatrics.
Yeah, the pediatricians are going to speak.
Hi, I'm Dr. Catherine Olmstead. I've been a pediatrician in Charlotte for 14 years, and I'm the pediatric physician leader at Novant Health. And my last 5 months have been very similar, I think, to probably what your last 5 months have been, which is how do we pivot from a world we've spent a really long time becoming excellent at to doing something completely new and different. And as you know, children are different. And just as school is different from an adult corporation, pediatrics is different from other healthcare settings because we couldn't stop. We had to keep going. So in March and April, pediatrics offices looked a lot like grocery stores. We had to show up every day. The week before COVID started, pediatricians in Charlotte at Novant saw 8,500 children. It was the middle of flu season. You know, viral incubation rates last 2 weeks, so we continued to see large numbers of sick children in our clinics, even after the schools closed. Daycares continued to be open for essential workers, so we continued to see sick children in daycares. And Novant obstetricians are delivering 1,000 babies a month. And all those babies had to come in for well visits and had to be seen safely 2 days after discharge, a week after discharge, 2 weeks after discharge, a month after discharge. So somehow we had to provide a way for those children to get safe care. And our commitment was to deliver remarkable care regardless of what the situation was. So we were seeing babies in the backs of SUVs in the parking lot. We required masking from the very beginning of COVID, and since there weren't masks available, we required parents to tie scarves around their faces, which was sloppy, but it's what we had to do to keep our patients safe. And now I'm very proud to say that we are back to our pre-COVID capacity. Last week we saw 100% of the same number of encounters we saw a year ago in the same week. Today I did 27 well visits in my clinic before coming here and answered many questions from scared young children who don't know what to do with masking and who wanted me to tell them, you know what, this virus has really been gentle to children. We have tested 15,000 children under the age of 18 in Novant. About 15% of them are testing positive. So we've had 2,000 children test positive, only 10 of them sick enough to be admitted, and only one of them became critically ill. And that was a child who had very, very severe underlying conditions and frequent hospitalizations from other viral infections.
Could you give us those numbers again, just like 2,000?
We've had 2,000 positives across Novant in children under the age of 18. 10 of them were admitted to the hospital. 9 of them went home very quickly. And some of those admissions were just precautionary, like a child who is on immunosuppressive chemotherapy for leukemia, comes in with a fever, happens to test positive for COVID, gets admitted overnight for a sepsis rule out, is asymptomatic the next day and goes home. So we've had really a remarkable experience of seeing that these children are somehow being spared from this virus. Of course, we hear reports, we read in the paper that bad things happen, and bad things happen to our children in lots of situations, but what our experience has been is this virus has been extremely mild in children, especially under the age of 12. We are seeing teenagers out in the community. They're going to the beach, they're going to parties, they're swapping the virus among each other, and still they're coming in asymptomatic for the most part, or with very mild symptoms that go away in a day or two. What we do see is adults spreading the virus to children. And so more than children spreading it to each other, which there have been theories that it's because of receptors, it's because children have cross-immunity from all the other coronaviruses in the community, it's because they haven't seen each other. Whatever the reason, we're not seeing a lot of child-to-child spread. What we're seeing is the child is moving from one house to another to stay with grandparents one day, stay with a neighbor another day, stay with an aunt another day while the parents try to work, and the children are getting the virus from those adults. So Our experience has been extraordinary. Right now, if you walk into a pediatrics clinic, only one parent is allowed to come in. No siblings are allowed to come in. Every staff member is masked. Every patient is masked. Every child is masked. And you'd be amazed to see these 2-year-olds keep their masks on. And the older children are extremely compliant when they are told that this is going to be the norm. And our children wear their masks in our clinics. We're doing all of our well care. We think it's extremely important that children come in for their well visits. And we've spoken broadly and publicly about how important we think the well visit is, even if the sports physical is not required this year, because that's where we address the anxiety that children are facing from this virus. That's where we address the depression, the food insecurity, the lack of safety in the home. So we're really encouraging our patients to come in for those well visits. And more, we're starting to see sick visits. We've been testing for COVID in our clinics, in our pediatric clinics for the past month. And a lot of that testing is being done in the parking lot, and we are finding that the rates are going up in our community. But we think that care is really, really important, that children have a safe place to go. So that's been my experience as a pediatrician, and I think a lot of the things that we've had to do with testing temperatures on all staff members before they come in. We take a temperature on every patient and every parent before they come into our office. We screen for COVID before parents are allowed to come, and if anybody has been exposed or had symptoms, they're not allowed to have a well visit. They have to do a video visit first, and then they can come in at the end of the day for testing in the parking lot or an examination once all the well children have left, which is probably going to be a very similar situation in the schools where everybody needs to be screened, and if there's any chance they've been exposed or have had any symptoms, then they're going to have to stay home. Because the temperatures are not always predictive. We are seeing about 40% of patients are asymptomatic, so a temperature screening is not always going to pick up symptoms. And 80% of people are so mildly symptomatic they wouldn't have otherwise sought health care. So asking those exposure questions is going to be incredibly important. I could probably talk all night because I've been talking about this for 5 months, but I'll stop there. If you all have any questions, I'm glad to take them. Okay, sure.
And Dr. Williams knows I could probably fix somebody's brain a lot, particularly in the back way.
I'm glad to.
And I'm David Olmstead, and I'm in the world of pediatric cardiology. Thankfully, COVID doesn't come to my office very much at all, and it doesn't impact children, as we just heard, but rarely it does affect the heart. It affects the heart a lot more commonly than most respiratory viruses in the sick adults who are admitted to the hospital. So there was a statement by the American College of Cardiology in May suggesting that athletes need to have cardiac screening before returning to sports, even if they are very mildly ill, sick for a day with a sore throat, but test positive. And the data is still not there, and the concern is because of the sicker adult patients that have had more cardiac involvement, does that translate to less sick people having more cardiac involvement? So the whole goal would be to prevent the catastrophic cases that might happen on the sports field. I know sports is not even really part of the discussion tonight, and if that does become a part of the discussion later on, I'd be happy to come back, but I don't want to extend this any longer about sports than that. But I'd be happy to answer any questions as well.
Do we have any more presenters before we go to questions?
That's it. That's it for the presentations, and feel free. We're here for as long as you have questions. So it's not on our end. It's not time limited.
Okay. And Ms. Cheek, any questions you may have that will educate the public, please just fire away.
So given the current trend, where we are today, what you've seen, what we've heard about pediatric cases, is it safe for us to open schools? Does any of you guys want to give us any ballpark on that?
We have a 6th grader and an 8th grader in CMS, and our family decision is that they will go to school in person if in-person school opens.
Okay.
I believe every family should have an option to not go to school if the family's in close contact with grandparents, if there's somebody at high risk in the home, but that has been our family's decision.
What should our data be in deciding if we have to pivot? Ms. Harris really couldn't commit to anything other than positivity ratings, but to me there must be some data points that you can help us with when we say, because I heard you guys say we may need to pivot quickly to, I think Dr. Little said that, we may need to pivot quickly to a more restrictive environment, or we may find that we are ready to pivot to a more open environment. That's one, so ponder that for a minute. One of the points that you all mentioned was the way that kids are getting it. I'm curious, is this all the way through 18-year-olds? I had originally heard it was younger kids seemed to do it better, but the middle, I have an 18-year-old going to Chapel Hill in a month. In 21 days, I move him into his dorm. And I have some anxious moments, but mostly about his behavior, not really about COVID. So I'd be curious do you think that our older students, the middle through high school, are going to see different issues than we will with the younger ones?
Under age 10, it seems like symptoms are very, very mild, and the children just aren't very sticky for this virus. We'll even see parents test positive, so they bring their children in, we test the children, they're negative. Over age 12, the older you get, the more likely you are to get symptoms and the sicker you're likely to be, and middle schoolers are in the middle.
Okay. And then the other thing we talked a little bit about, Dr. Little brought this up with his atrium employees. I think Dr. Williams, you did as well, that there's more of a risk of hanging out in the break room and spreading it to each other and having maybe not made the greatest choices on the weekend or in your time away from work that led you to become infected and then bring it to your coworkers. So I think that the reason I'm bringing this up is I think there's a good bit of fear in our staff that they're going to get infected from children. I think that the reality, and I'd love to hear from you, what I hear is that they're probably more likely to get it from other teachers and other staff, not from children.
Yeah, there are no easy answers here, so I don't want to make it seem like it's simple. Our experience is the same as Novant. I think you can look at it in maybe two cohorts of kids. The younger kids below 12, 11, they don't seem to get it as easily, and they don't seem to spread it to adults as easily. Again, there are no absolutes here, and as I said, we are learning as we go. I think you should treat the adolescents like the adults in terms of their getting the virus, any complications, et cetera. With regards to your question around who's more likely to give it to whom, I think you need to be transparent with your teachers and staff to say, look, as we know it now, it's more likely that an adult will give it to a child. But again, you got to sort of balance that with the fact that there are way more children in the classroom than there are adults. So I'm not sure you want to go down that path, because how do you weigh which one is more important, the volume of the number of kids or the adults passing it to the kid? I think it's more important to focus on what you're doing or what you plan to do to keep people safe and why you're doing it. And just really focus on those behaviors that you want your teachers, your other staff to do in and outside of the school, so that they understand why you're doing it. The why is so important. I think it's more important to focus there. That's what we've tried to focus with our teammates. It's the culture you're trying to build around safety as it relates to COVID in this situation. And just reminders all the time. That's why I said the communication is so key about the behaviors that people need to be doing.
Do you have any specific data points that you think that we need to look at in our schools that would help us to decide, is it time to pivot? I know Dr. Mutch is shaking his head too, but is there certain things that we need to look at that would say pivot to more restrictive or less restrictive?
Yeah, I mean, I can't, say exactly. I think one is you got to define what outcomes are important to you, right? And so once you define the outcomes, then you can define how you measure whether you're reaching those outcomes or not. Obviously, you're going to have to define there's some number of infected kids and or staff at a school that you're going to have to pick, and there's no magic number that where you say, okay, we're going to shut it down. I mean, and I don't know what that number is for you, but you're going to have to pick a number and go with it and then learn as you go with it. So you want to know how many infections you have, how many infections are happening, or picking up each day. You want to know the community rate and how many new cases are happening in the community. You can look at that as sort of the 7-day average or the 14-day average of new cases. We look at something called the R sub T or the R sub naught, which is a fancy way of saying, if you got one patient infected, how many people then do they then go on to infect? And you want that number below 1 is ideal, because that means for every one infection, they're infecting fewer than one person. So that means that eventually the virus would die out. Above 1 is, around 1 you're cautious. Anything above 1.2, that's when the virus is starting to spread rapidly. And so that's a number that our analysts produce for us. I haven't seen that produced by the county or the state, but that would be a very helpful number for you to have, because that would tell you how quickly the virus is spreading from person to person.
That would be one of the things I have a lot of people ask is, well, how dare you send kids back to school, or how dare you do this? We don't want anyone to get sick. And my response back is that's not even realistic, not unless we shut down for 2 years, as I said to Gibby Harris earlier. But, my risk tolerance is 0. But my risk tolerance for children to have social and emotional needs at home is 0. And my risk tolerance to children being nutritionally fragile is 0. And all my risk tolerances that are 0, they're not congruent. They can't work in the same environment. So I have to kind of decide what my tolerance level is. And I think as a board, that is something, as a system, as a staff, we're going to have to say, if we have 2 kids infected at a school, are we going to freak out and shut it down? We kind of have to start thinking in those terms, because 0 isn't real. 0 will not be the case unless I'm misunderstanding the nature of this virus. 0 is not going to be, we don't operate in a world of 0 right now.
Yeah, and that's exactly it. It's inevitable that if you open the schools, if you decide tonight to have whatever, and however you decide to open that, you will get cases. And you will have to, again, have robust communication plans and response plans of how you respond to that. And as long as you can put the protections around it and isolate those kids or staff away and quarantine them for the recommended period of time, you will stay on top of this. But you'll have to wrestle with these issues. And again, they're not easy issues to resolve.
And then the secondary part to that is if our risk tolerance is whatever it is, and we postpone opening, we keep us in a remote only, will we face those risks at some point unless we stay locked down for...
Yeah, I mean, again, I'm not an expert in this, but I think you're balancing risk, right? It's the risk of, if you open in some capacity, of infections, and ultimately the worst case scenario, someone dies from it. But you're balancing all those other risks of social and other needs of kids and developmental needs of kids, food security. What do you do in the special circumstances for kids with health issues, other developmental issues where in-person learning is better for them? You're balancing those risks. No matter what decision you make, you are elevating one list of risks over another. So it's not an easy decision to make. Whether or not, how long this is going to play out, I don't have a crystal ball on that one. All indications are that this virus is going to be around for a while, and I would say at least the next 6 to 9 months. We're still speculations on a vaccine of when that becomes available, the effectiveness of that vaccine, how long the immunity lasts, etc. How do we mass and immunize the population? I mean, all indications to me are we're going to be living with this virus for the next year and a half. That's me speaking as a sort of test in the wind. just based on all the things, the challenges we have to face. So if you don't open now, when could you open? I mean, you could be looking at next fall. I mean, that's a possibility.
I so appreciate your insight. I appreciate all of you medical professionals. I still feel like a kindred spirit to you, and it's so helpful to me to actually hear your voices and your input.
So Ms. Byers-Bailey and then Mr. Strain.
Thank you. I just have one quick question. I heard the comment that kids don't pass the virus to kids. Adults will pass the virus to kids. Do kids pass their undiagnosed virus to adults?
It's a great question, and we have no idea. We don't know if the reason the adults have the virus is because their children exposed it to them. I think the problem we have in answering that question is that studies that have been done worldwide in children in group care settings have either been done in the United States during lockdown, when children were not interacting very much and adults were staying home, working from home. And in other countries, schools have opened after the rates have gone down in the community. And so there hasn't been a lot of child-to-child transmission, but those are in areas where the rates in the community are going down. So we don't have the data to make an educated guess to answer that question at this time.
Okay, thank you.
Mr. Strain.
So I'll probably follow up on that question. I'd like to understand if there's any sort of physiological explanation for why our younger children are not contracting the disease at the same rates. They're not spreading the disease at the same rates. They're not seeing as serious of symptoms. Is there a physiological explanation for that?
There may be. There's theories. As Catherine said, that coronavirus is a general term for different types, a class of viruses. And there are other coronaviruses in the community that kids get all the time. Those recent infections carry some immunity, possibly. There's also that you may have heard about the ACE receptor on the cells as the portal of entry for the virus. And that I was reading one study about lung biopsies in children have fewer of those receptors. And so does that mean that they'll get less sick because they don't have as much virus load in the lungs? So those are all possibilities. I don't think anyone knows for sure. And I think no one knows for sure where this is headed. And kind of what Dr. Little said, at some point there's a decision you need to make and move forward. And I trust you all will make a great decision. But we have to take a step out. And I was just sharing with Catherine, I said, we haven't closed a single clinic because of transmission and outbreaks in clinics. And what we're doing in clinics is exactly what we're proposing, or the proposals would be in schools.
Right.
And yes, it's a different setting, and yes, the ratios are different. But I think that does carry some reassurance that distancing, masking, using appropriate ratios make this a reasonable thing to consider.
You just hit on one of my questions, which was about the clinics, the experience in the clinics, and I appreciate you bringing that up because it is very similar, because we are proposing the same precautions, and it's very important to understand what that experience has been. If I could pivot for a minute to what happens when kids don't go back to school. So you mentioned that you're a father of two, I'm a father of four. My four are going to go back to school, given the opportunity to do so, one of which is at moderate risk. So I've got to take those things into account as well, as a family, obviously, but as an individual as well. But what risk is being highlighted? Dr. Redfield, when he was in town, talked about it being more harmful for students to be home, to continue to be home for an extended period, than to actually go to school, given the risk profile that we've just described. So what sort of risk or issue was he highlighting there for continuing to have
for staying
kids?
at home, the risks of staying at home?
Right,
is
right.
what you're getting at?
Yes.
Well, what I would see would be the risks of mental health, of food scarcity, of all the things that have been mentioned. I can't remember who mentioned about the rates of suicide going up across the country. Suicide's the second leading killer of kids 10 through 18, I believe it is. So if those rates are going up, there's going to be a whole lot more death from suicides than there would be from COVID. So I think that's one fear that I have of keeping kids at home. And then especially all the more vulnerable kids in social circumstances that may be getting missed. So.
And are you seeing increased levels of those risks manifesting themselves in your practice?
In my pediatric cardiology practice, I'm not.
Right. Okay.
What we have seen is a decrease in the rates of pediatric cancer diagnoses because patients have been scared to go to clinics. We've seen in the adult population, parents scared or adults scared to go in to get their strokes evaluated and heart attacks evaluated. We've seen an increase in ruptured appendectomy or ruptured appendices because parents are scared to go get an evaluation when we've set up a very safe environment to provide that care for children. We've seen decreased rates in reporting of child abuse, but a lot of concern that there might be increased child abuse since we now have a large population of adults out of work who are also struggling with their own mental health issues and now trying to juggle homeschooling as well as trying to find jobs. So I think there's a lot of concern in the pediatric community that the school is a very safe and stable environment where social distancing and masking can be enforced the way we do in clinics in a way that can't be done as well when jumping from one daycare situation to another out in the public.
Thank you very much.
Okay, I see Ms. Marshall and then Mr. Schul.
Thank you all so much for joining us tonight. I've got some questions in terms of immunity and what we see in this virus currently. So I have, and we could spend so much time thinking about what this virus has done initially and what it's doing now. Do you sense that this virus is different now than what you saw earlier in the year? And that may not, that may just be, and it may be that we really have to go back to what happened in Europe since we've just gotten it. So that's one of the questions. And then immunity. What do we know about immunity at this point with this virus?
That's a really good question, and unfortunately we don't know a whole lot about immunity. What we do know is that generally with these kinds of infections, you produce protective antibodies, one called IgG in particular, that does provide long-term immunity from many different kinds of illnesses. And internally, with looking at our own employees at Novant, we are checking IgG levels on team members who've had it, and we are seeing a high rate of IgG antibodies, which is very reassuring. However, we don't know for sure what that means in terms of, is it related to other coronavirus exposures or is it related to this particular COVID-19 virus? We don't really know. We also don't know how long this immunity will last, but we are getting more information about it as we go. There was an interesting study that came out recently that said that there does seem to be an increasing incidence of recurrent infections of COVID-19 kind of across communities, that immunity may only last 3 or 4 months and people may get a second infection after 3 or 4 months. They may even get several. So it's very much an evolving playing field right now. We're going to get a lot more information, I think, over the next several months. And I think that most importantly, it's very hopeful that vaccines will provide a much higher degree of immunity for a longer period of time. That will come out, I think, over time also.
Can I just do one quick follow-up in terms of vaccines? And just sort of as a public service announcement, too, you cannot overemphasize folks getting their children vaccinated for the diseases that we normally get them vaccinated for to enter the school building. And then the importance of the flu vaccine. I mean, I know many adults don't get it. I think everyone has to really consider that this year. That will be first on my family's list to do that.
Yeah, absolutely. You know, we are 100% supportive of flu vaccination programs. At Novant, we have a mandatory flu vaccination program. Atrium does also. Many healthcare providers do. It's really important to do that. In the upcoming flu season, when flu season may be very bad, and if you throw on coronavirus on top of that, who knows what kind of morbidity and mortality it may have ultimately. So absolutely, I would absolutely recommend you really do everything you can to get the word out to all your students, all your faculty to get your flu shots.
Thank you.
Thank you. Mr. Schul?
So we had some discussion earlier in the meeting about asymptomatics, and I still had some questions about it. So generally, how infectious are asymptomatic carriers? What is the risk of an asymptomatic carrier?
All right, so again, I believe in trying to keep things simple and be honest about what we know, what we don't know. What we think we know here is, what we do know is that people are able to spread without symptoms. Some of them will never go on to symptoms. That's to quote asymptomatic person. Some of them are pre-symptomatic, meaning they will develop symptoms, but they were spreading it even before their symptoms developed. And we know that only because of the contact tracing and who ends up getting infected by those positive confirmed cases and when they had contact with that confirmed case. As far as like how infectious they are when they're either pre-symptomatic or asymptomatic, that's a hard, there's no really real way to define that. I think it's enough to say you don't need to have symptoms to spread this disease. And that's one of the things I said earlier is this virus is a bit different than other ones, where usually we can use that onset of symptoms as the time someone becomes infectious. This is different. This is different. So, yeah, I mean, I think for all intents and purposes, you have to act as though everybody has it and they could spread it to you.
Thank you. So then the screening that you were describing, and similar to the screening that I had today when entering this building, and I think a lot of screenings around, how confident are you in a screening that is, a set of questions about symptoms and a temperature check? How confident are you?
Yeah, I think, again, by itself, it wouldn't be anything, right? I mean, this is layers of protection. So we tell, and I know Novant does as well, if you have symptoms, do not come to work. We have mandatory masking. We've done all the other environmental things I talked about earlier. We do that as another just safety check, just to pick up, anything that might slip through. So in terms of by itself, no, you wouldn't just do that. You have to have all the other things around it as well.
Okay, and last question. When is a student no longer infectious? So when should our protocol be for when we can get a student back to school?
Yeah, we follow the CDC guidance on this, and there are essentially kind of two ways to clear somebody to come back. The CDC basically says 10 days from the onset of symptoms, or if they didn't have symptoms, you can use the positive test date as that date. So 10 days after that's when they're clear. But with the caveat that they have to have, essentially their cough, shortness of breath have to be gone, and they can't have a fever anymore. And they can't be because they use Tylenol or Motrin. They have to have no fever without medications for at least 3 days.
Thank you.
Okay, Ms. Schiff and then Ms. Sawyer.
And I think between Ms. Marsha and Mr. Schultz, they kind of said some of the things I'm interested in hearing about too, and that with immunization, because as we look at our kindergartners especially, how are we going to look at that this year? Especially because we had protocol for our students when they did not come with immunization. So I would be really concerned how we want to look at that, especially now when we really had to sometimes look at them not being able to come back because they did not get the immunizations or the health checks.
I would not change the immunization requirements for the school for the coming year. All the pediatric clinics at Atrium and Novant have continued to be open and functioning. We're all seeing well child checks for all ages. We have outreach community care cruiser vans going into areas where there may be healthcare disparities, offering immunizations to children. And we'd be glad to partner with you on that, on trying to get children their necessary immunizations. But as was mentioned before, the decrease in immunizations is becoming a public health crisis in this country, and it's out of fear in the public and not out of safe options for children to get immunizations.
Thank you, because that's a major one. And also, going back with the flu shot, one of the things that we stress with teachers especially, and I would really want to be stressing that again this year, is that they take the flu shot. We even had CVS and other facilities to pair with us to come out and even make sure that some of the adults were getting the flu shot. And I really want to talk about that because there was some correlation, I think, between the flu shot and COVID in terms of, explain that.
Well, for starters, in adults especially, the symptoms of COVID and the symptoms of flu are identical. And so it's very confusing to know whether the patient, once we get into flu season, has COVID or flu. And second, we found in children that about 20% of children are co-infected with another virus. So when they test positive for COVID, they test positive for one of our other routine pediatric viruses as well. And so it's very likely this winter that we will see children come in with both flu and COVID. As in the past, we've frequently seen children come in and test positive for flu and strep at the same time. And so I think in order to protect our testing capacity, in order to get parents back to work, in order to get children back to school, it's going to be incredibly important for everybody to vaccinate for flu, because the way our testing is now, it's several days sometimes before you can get a test result back. And if we're not able to tell you definitively that your symptoms are not COVID, you're going to have to follow the guidelines for getting back to school and work.
Thank you, because I know it's critical with the flu shot, especially in adults in certain ages, they need to have it. And that will support our teachers. Thank you.
Ms. Sawyer.
Thank you. You mentioned encouraging your staff when they're ill to stay home. Teachers and our staff are notoriously dedicated. If every teacher that had symptoms stayed home, our schools would be empty a great deal of the time. And we learned from Dr. B. Harris earlier that we don't have access to a rapid test. We are faced with a 5 to 10 day lag if we can get staff tested. How do we handle staff who have symptoms and we don't have a definitive rapid test?
That's a great question, and I actually stood up to just say that, and this answers your question a bit, and I'll have some of the others speak, but one thing that we really haven't focused on that I think we really need to understand is that we have to create a culture change, okay? We have to view health as a shared value in our community. We have to understand that what I do impacts you, and you, and that we're in this together. It may sound corny, and it may sound idealistic, but if we are able to understand that health is a shared value in the community, okay, there's a lot of things that we can do to prevent and mitigate the spread. And so I don't want that to go unsaid tonight. We talk a lot about the technological advances, we talk a lot about the science, but it's really important to understand health as a shared value from a cultural standpoint. And I'll just
Can you explain what are you saying? People need to stay home if they have symptoms. Is that what you mean by health as shared value?
Yeah. So exactly. So I asked a question. I was at a forum about a week or two ago, and I asked around the room. I said, "Do you think my health impacts your health?" And I went around the table, and it was about 50% that said yes, and 50% that said no. And that was a bit shocking to me, that there's not an understanding throughout the community that my health and my behaviors directly impacts your health. Okay? And so it's hard, right? Because if you have a parent that needs to go to work, and then you have a child that may have a little bit of a fever, and so you gave them a little Tylenol and rush them off to school, okay? That's what I mean about health as a shared value, culturally speaking. I didn't say it was easy. But it's something that I think we need to talk about and perpetuate because we're all in this together as a community.
One of the challenges that we face in pre-COVID times is a shortage of substitute teachers. So that for the many times that we cannot get a substitute teacher, and I might add especially in some of our most challenged schools, what happens is the class is basically doubled up. Well, if we have to do that, we're violating our social distancing.
I think that's an excellent point to bring up, and definitely when my children come home and tell me they've been dispersed, I always ask them, so what did you do in the back of that other classroom? What did you learn? And I think the tools that your team has worked on over the past 5 months to build this virtual learning platform is going to be incredibly powerful in those situations when the school has to pivot from an in-person learning environment to a virtual learning environment, because you can double up a class through a computer in a way that you can't in person. And I don't know how you do that. I'm sure it's technologically extremely challenging and very difficult for teachers to integrate their curricula, but I can see in the future someday an ability to do that kind of virtual learning. The way we are doing video visit exams, I never thought I would feel good about. And I would love to see that virtual platform be the backup plan for when the teacher has a fever or a student in the class or a couple students have a fever and that class has to quarantine. If they could pivot to virtual learning during that 14-day quarantine window, I think that would be an incredible accomplishment.
Anybody else? I have a question too, but Mr. Strain?
Yeah, so we've talked, in fact, when Gibby Harris was here, we talked about some of the tracking, some of the dashboards, some of the sort of public health figures that are so critical and would drive some of the decisions, not only decisions, for example, within your clinics, right? If you look at the health of a clinic, but also the decisions in terms of, for us in schools, about the public health and the risk associated with putting groups together, even when properly distanced, masked, etc. So I wonder if you could speak for a minute about some of the data and analytics work that you've done, what that tells you, some of the dashboarding that has been put together, and perhaps what that's telling you both in terms of the health of our county today and perhaps some of the modeling moving forward.
Yeah. Thanks, Sean. So internally within Novant Health, we've, from the onset of COVID-19, we were very in tune with the fact that we needed to first understand from a global perspective, down to a U.S. perspective, down to a county perspective, what was happening within our community and abroad. And so we quickly developed a COVID-19 dashboard that showed us from a global point of view what's happening, but then quickly zeroing into on a per acute facility perspective within each of our acute facilities within both the Winston and the greater Charlotte market, as well as in Northern Virginia, where we know at the onset of COVID-19 that was really a hot spot for us, really understanding what was happening from a population perspective within that environment. And so we then took those learnings, and as we started to think about how do we maintain our work staff and bring them back to work safe, some of the technologies that I mentioned earlier, we made sure that there was a reporting and analytics piece wrapped into that. So when you think about pre-screening, I heard the concept of, folks may come into work and not feel their best, but we're hoping, right, to Dr. Williams' point, that those pre-screening technologies allow folks the opportunity to see the questions, answer the questions, and answer them correctly. But in the event that someone does screen red or they screen yellow, you're tracking those results. So now you can be proactive. We're pushing those results back to points of contact, key administrators on your side, so that you can be proactive in the way that you go about managing potential risk, right? So getting ahead of risk is important from a reporting point of view. And then from a surveillance point of view, when you do run into a situation where someone has contracted COVID-19, dashboarding and reporting and tracking case management throughout that process is important as well. So we have adopted across the board within our environment a robust way of tracking at a global scale all the way down to the individual acute facility point of view, what is happening on a day-to-day basis, both for our patients as well as for our employees. I think it's critical, right? We talked a lot about technology as a virtual, and technology by itself does nothing but processes, workflows, understanding the data and being proactive in the way that you go about viewing the data and acting on the data is going to be critical.
Thank you very much.
I think one of the other pieces of data that will be really important to you, and I know we are looking at this, is as you get to that granular level, looking at your at-risk populations. So we know that in certain ethnic groups, they are testing at a much higher positivity rate. So our Latino population is testing almost 30% positive rate for every test we do. And so your schools are serving those same communities, and so your protections, your responses, the resources you allocate are going to need to be in line with those numbers, right? So if you're seeing positive rates of 30% in the area around the school, what you do in that area is going to be very different than an area around a school that's testing at 2% positivity. And the resources you provide need to be commensurate with that. So I think in terms of the specific data, you need to look at it at that geographic spread as well. And where are the positive cases, and how does that impact your school and the students that go to that school and your teachers that work at that school?
Can I just follow up? For lack of a better term, if we call that a hotspot in the community,
right?
Then is there a potential for the school to actually be a forum of education within that community to help to address some of the spread within the community as well?
I mean, absolutely. I mean, I think some of the challenges that we saw early on when we were trying to roll out testing was, trust. And as you need that trust for them to be able to then accept your message. And, it seems like you all have trust because they're sending their kids to you. That's a great opportunity to leverage that trust and, again, spread the gospel.
I appreciate that. And since you mentioned sending, I know the pediatric doctors are going to send their kids. Do you have kids that are school age?
I do have two kids that are school age, 14 and 12, but they go to private school. So we're having the same conversations for that.
Sure.
And one of my kids is at risk, so same types of discussions in my house.
Right. And still a decision to be made, or has that decision been made?
Yeah, I think our position, my wife and I, is that we're going to send our kids to school if that's what's offered.
I have a follow-up to that. If your kids were to happen to go to a school that was predominantly populated by a group, like a demographic group that has a 30% positive rate right now, then would you be comfortable with sending your kids to school?
Yeah, that's a good question. I don't know. I think but that's something that we would weigh heavily, and it would depend on what the school is doing to protect the kids and the staff. I mean, I think that's important. And again, that's where that communication piece comes in. And my kids are old enough that we're having discussions with them about what they want, right? So my 14-year-old, what do you want to do? How do you feel safe? Because I'm not the one that has to go to the school. So we're letting them make decisions for themselves. So I think that's an opportunity in and of itself, right? But yeah, I think it's an important question. I think, sorry to put it back on you, but it really is, at that point, I would say, well, what are we doing to protect our kids and our staff?
Duff, I saw Ms. De La Hara's hand too, but is this directly related, or?
Well, it's kind of following up a little bit on what you asked. So if that's okay, can I go? I appreciate your question and thinking about the different subgroups, and you spoke about, presumably, we have that trust, in the schools. On the other hand, I do have a lot of interaction with the Latino community, and I'm getting a lot of feedback that they are very scared and don't want to be in the in-person classroom setting. So I guess I just wanted to mention that, because yes, there may be a sense of trust, but there is a great, great deal of fear. So I don't know that we would have that opportunity, at least on the front end, for the education that's maybe being presented. I think we should strive for that, but I just felt like we needed to mention that. I also wanted to mention, because you were talking about it would really depend upon what we do, how we handle and where we allocate our resources. And of course, funding for all of this is an issue. And I can't help but just sit here and be sort of struck by how impressive all of your systems that you're describing, what you're able to do in a medical facility. It sounds fantastic. On the other hand, I'm fearful that we don't even have enough nurses in each of our schools. So I guess I'm just kind of speaking out loud. I don't know if this is a question yet, but just kind of acknowledging where you are and what you're able to do. And then, maybe that will later be a question back to our staff on what we're able to do. Because I'm just not sure it's the exact same environment. I mean, we're not a medical facility.
Yeah, and look, this is a challenge, right?
Yeah.
Hospital systems are losing money hand over fist because of this, for many reasons. And so, but this is the challenge we face, and so we're taking it on. But we've got a lot of the same challenges that have been mentioned. We've got, people who can't work because of health conditions. We got to figure out we still have to pay them, but we still got to figure out how to get somebody to do what they were doing.
Right.
We've got people who get sick and have to call out, and then they got to stay out if they got COVID. We've got people who have to stay home with family members. So a lot of the same challenges. I'm not saying it's easy, and the funding is definitely an issue. But it's an existential challenge that we're all facing.
Just to pivot for a moment, I was reading an article that just came out today, and I don't know if studies have come out prior to this that you may have been privy to, but talking about now they're able to show that the virus is passed on to the fetus, to a mother carrying a child. Have any of you seen that at all, those studies? I mean, the article just came out today, and I guess I'm concerned about our pregnant employees and what that would mean and the risk there, because if they're just now proving that it's happening and the babies aren't even born yet, we're not really able, I presume, to know what effects that may cause.
That's correct. So we don't know what the effects on the fetus might be, especially if the mom is infected earlier in pregnancy, because this virus is so new. What we do know is that women who are pregnant do seem to have a higher risk of complications from COVID. And what we have seen anecdotally is that the babies that we have admitted who are COVID positive, even in the first week or month of life, have done incredibly well with the virus and gone home from the hospital without any interventions.
Ms. Sawyer and then Dr. Jones.
I just want to go back briefly to your comment about our schools that have, that are serving communities that are showing infection rates in the 30% range. And those are schools in my district, in my neighborhood. Those are also schools that often don't have great HVAC systems. We have schools that, the teachers have, individual dehumidifiers in the room to make the room habitable and not mold stuff that's on the walls. Referring to.
Yeah, I think nothing in particular. It's just more that what we've seen is in those hot spots, when we're testing those populations, we're not just doing testing. We're screening for food insecurity as well. We're screening for other things as well. So we provide virtual social work services. We also try to set them up with primary care access if they don't have it. So again, I'm not an educator. I'm not a teacher. What I was speaking to is that we're not in those populations. We understand that COVID is one issue, but there are other health-related issues that we need to address.
Services.
Wraparound services, so that we're trying to take on the other things that we have been trying to address with those populations, but haven't really got a foothold there. So this is an opportunity to put those other resources around that as well.
Okay. Dr. Jones? No, you're done? Okay. Anybody else? Because I have one question. It was early on in this presentation. I can't remember if it was Dr. Little or Dr. Williams, but one of you spoke of, we're all, obviously we're wrestling with lots of different conflicting risks here. And one of those risks, one of you mentioned, was the mental health of employees. So not only are we concerned about the mental health of our students, but also the mental health of our employees. And I have to say, I've been struck really in the last couple of weeks as the numbers have climbed in Mecklenburg County, so has the anxiety level of our employees as we've been approaching this decision. It is through the roof. And so what do we do about that? I mean, it's real. And so I guess I don't know if that's a question for you all or if it's, I don't want to say it's unwarranted because people have really good questions that are unanswered. And we're all trying to make decisions based on data. And yet it seems that the data's evolving. And there are a lot of questions for which there are no answers. So, and yet at the same time, I think some fear is based on maybe misunderstanding the data. I'm still learning how to interpret the data. I've learned a lot tonight about what those climbing charts mean. So I guess I want to ask, do you have advice on how to, where we can truly reassure people versus where we just have to acknowledge that there's a lot we don't understand yet about what really is safe?
I appreciate that. And I have to say a large part of my leadership experience the last 5 months has been coping with healthcare worker anxiety. Early on, we had to go to work because babies needed us there and we didn't have a choice. But we were reading stories about what was happening in Italy and Spain and then New York. And yet we were getting up and going to work. And our nurses were scared, our doctors were scared. It was a terrifying situation. Is there going to be enough PPE? What kind of PPE do we wear? What kind of procedures can we do in our clinics safely? What can't we do safely? If the baby cries, am I going to get COVID? On and on and on. What if the baby coughs in my face? Because that happens to us all day, every day. So very, very aware of how terrifying it is to have a patient with COVID right in front of you, and we're all still dealing with that fear. I can tell you what's helped for us is to be incredibly compassionate that everybody is dealing with this pandemic from a different point of anxiety. Some people are terrified because they've lost their job and they don't know how they're going to take care of their family. Some people are terrified of the health risks. Some people are scared that their children won't have education. Others are scared that their children won't have food or social interactions. We're all coming at this with a lot of fear. And so having compassion and figuring out where each team member's anxiety stems from helps us to approach that. So our approach as healthcare workers was, if you're at high risk, either because you have health issues or you live with someone with health issues, or you're just terrified, which is perfectly normal and natural and understandable, we're going to figure out a way for you to work virtually at first. And so we had those providers working from home doing just remote visits. And providers who felt more comfortable would come into clinic with their masks and their gloves and see patients in person. Because again, everybody's coming from it from a different point of fear. And over time, we learn and we get desensitized, and things that terrify us less. And that's how we cope with all the fears in our lives. And once you've swabbed a patient with COVID and then gone home and taken a shower and hugged your children and not gotten sick, it gets easier and easier and easier. And the more we experience it, the more we learn, the easier it is to come back to work. It's hard, and in a school system this size, I don't envy this decision for any of you. But as much as we can honor those opportunities for those who are living in fear to work remotely at first and give them a chance to ease into it, I think that's how we deal with this fear. This virus is not going away this school year. And we're going to all have to come to a place where we are either comfortable dealing with it or we're not.
I'll double down on what Dr. Olmsted said there. I'll add a couple things. One is, some of the things just from a nuts and bolts perspective, just understanding what you already have in place. I would imagine through your HR systems, there are employee, health resources, things available. Partnerships with the local health systems, Novant and ourselves, in terms of mental health availability, counseling. There are things that we can do to come in and do virtual sort of lectures on wellness and health and wellness. There's a lot of things that you can proactively do to get out in front of it. So that's one thing. The second thing is, I think you will be amazed at the resilience and the bravery of your folks. And yes, there are gonna be people who are very anxious and fearful, and as already been stated, you'll deal with that, and you have to be compassionate and empathetic to them and their situations, and you have to deal with those. But you'll also see just people stepping forward and volunteering to do things. And I think about, at one point we said, if you're over 65, you don't need to see patients directly. You do the virtual visits. And we had 66, 67 or older doctors, nurses saying, no, I want to do this. Don't take me out of doing work. I want to work. I want to see patients directly. So I think it's easy to focus on the one side, but don't underestimate how much your folks will want to step forward and want to help and want to be there for the kids and for their team. You'll be amazed by that.
All right. Dr. Jones.
I'm sorry. I was making the point that teachers are caring teachers. They want to teach their students. they are in the hundreds, fearful of the environments that they will have to go into. Many will have to go into some schools in which the buildings aren't safe. For instance, Gibby talked about the fact that what is safe for a classroom environment. Good air circulation. We have schools, the HVAC systems are just outdated. They aren't there. Students need to be 6 feet apart. How do you do that when you have classroom space? You don't have the classroom space to do that, according to the numbers of students. So there are so many variables out there that rightfully so make teachers fearful. Caring, loving, talented teachers. And we're going to have a lot of teacher absenteeism. And that's going to mean that we crowd more students into classrooms together. So we need to know that and speak to that. There's inequity in Charlotte Mecklenburg Schools in terms of the buildings and the environments. So some people can feel pretty safe about their children returning to school. And teachers can feel pretty safe about going to those schools. But I hear repeatedly from, and rightfully so, teachers justifiably having that concern. I just need to put that out there in the space.
Good evening, and I want to thank you for bringing that into the room. Both healthcare systems, Atrium as well as Novant, we're all concerned about the equity component of the work that we do. What's not known by most is Dr. Little, Dr. Williams, and myself, we meet weekly. The two healthcare systems, we meet weekly, and we talk about just that. We're focused on how do we ensure that those that are impacted by this, the greatest, those that, as I've heard us talk about, the slide that's going on, and these kids not being in school since, physically being in school since March. These are real concerns. And so thank you for bringing that into the room. That's part of the discussion. Madam Chair, when you mentioned the mental health, I believe as Dr. Little was speaking, every doctor up here and administrator will tell you that we ourselves are having conversations internally about ourselves and our mental health. We have micro communities that we've developed where we're dialoguing with ourselves because all of us are experiencing this. So I think the answer to your question is the honesty to make everyone aware we're all experiencing this and that we're not, no one's in this alone. That feeling that they feel is not something that they themselves are feeling alone. So I just wanted to say thank you for bringing the equity piece. It is something that we continuously focus on, and we could talk about all night, but that's not the topic for tonight.
And Mr. McGregor and I did a year-long journey together of LDI, doing a deep dive into equity issues with partners across all sectors in the community, and it was quite a journey, and we, really unpacked a lot of the structural racism that exists in our community. And who would have ever thought that we would be here today dealing with this pandemic tonight, and that is laying bare the equity issues and in fact magnifying the equity issues in our community. And to that, I just have to say that it's really wonderful to learn from your experiences. You're ahead of us as an institution powering through this pandemic. But there are two very big differences between your institution and our institution. One is that you are all medical experts. And the other is that I suspect that you guys are much better resourced than we are. So thank you so much. I don't know if we have any more questions. All right. We do need to get to a motion and a debate and a vote, but we're going to take one more quick 5-minute break, and then we'll do that. But thank you ever so much for your time.
Can you get through? Oh, yeah, you on trim, ladies. I like the fact that you have this whole.
Our 5-minute breaks
all of
are
this
always
set up in
2
your
minutes.
house.
Finished products. There they are. There's a set.
All right, we're back at it. So, Mr. Winston, Mr. Superintendent,
Yes, ma'am.
do you have others to present to us tonight?
Yes, Madam Chair, thank you very much. We've had lots of staff who've been doing tremendous work around our planning process for the 2020-2021 school year. And at this time, I would like to ask Dr. Matt Hayes and Mr. Charlie Jeter to come forward and share some more thoughts about our planning.
Thank you, Superintendent Winston. We appreciate the attention this evening. Just want to bring everybody back to the 2 weeks ago in a meeting that we came in front of you and we presented 3 plans. Those 3 plans were based off of guidance that we received from the governor, also from DHHS and the State Board of Education. In those scenarios that were 3, there was a scenario A inside there. That scenario in that plan that was developed was if the virus was contained. The scenario B plan was where if the virus was slowed and the flattening of the curve and social distancing would be required inside of our schools. And then also the final plan, which was C, which would be put into place if the COVID metrics worsened. I just want to lift up to the board that was we were waiting on the governor to make a decision on which of those 3 plans he would announce that he would recommend that all of the LEAs throughout the state of North Carolina would put into place. At this point in time, I'm going to ask for Mr. Charlie Jeter to come up and discuss what it was exactly that the governor did put into place. Thank you.
Members of the board, Mr. Superintendent, Madam General Counsel. Yesterday, the governor announced his recommendation based on the guidance and the information Dr. Hayes just shared with you all. His recommendation was for option B. However, before I suggest that is his determination, under Senate Bill 113 that was passed about 6 weeks ago, the General Assembly has allowed any local governing body to implement a plan that is more restrictive than Governor B to ensure the health and safety of its students. So as a result, the governor has allowed y'all to do B, which functionally what that meant is it took A off the table. So for those that have been requesting on Facebook and asking those questions during tonight's meeting, what the governor's decision did was make it so option A, which is full in-person instruction, is not permissible in North Carolina at this time. The only choices before you tonight are some hybrid model, which is option B, or a full remote option, or option C, understanding that a hybrid model can take many different forms from many different school districts, and they're all doing the same way. And so that is what the governor recommended yesterday, and that's why we're here tonight, for y'all to hear the options and to make a decision. Happy to answer any questions.
All right, do we have any questions about the legalities and the governor's order and the various options? No? Let me interrupt you, Dr. Hayes.
Let me interrupt you, Dr. Hayes.
I think we may have lost the feed. Okay, we need the public to hear this. Okay, we need the public to hear this.
And I can't see.
I'm so sorry.
And I can't see.
Yeah. Yeah.
Yeah, can we move it over? Yeah, can we move it over? Oh, is there any way? Oh, the camera.
Yeah, it's pale. Yeah, it's pale. And I need to read it and hear it. And I need to read it and hear it.
From here on out, we're either doing Zoom. From here on out, we're either doing Zoom or we're doing the government center.
How are we going to go from person to person?
do.
One, two, 1, 2. One, two, 1, 2.
So there's a pause, there's a delay.
I'm hearing that people can hear us. I'm getting messages that they can hear us. On some platform.
That just repeated.
All right, you know what? We're just going to plug through. There's a metaphor in here somewhere. So let's keep plugging away. And if we lose this again, we'll pause again, because this absolutely has to be done before the public. So thank everybody for your patience. Thank you, Dr. Hayes, for your unending patience.
Yes, ma'am.
Let's try it again. And I think we can pick up with the next slide. I think we got through this slide. I think we can pick up with that
That's
slide.
fine. Yes, ma'am.
And we will pause if this goes down again. Let's go. Okay, thanks.
Not a problem. Thank you. So once again, based upon the Board of Ed feedback, we are here today to present Plan B plus remote. I'd like to go over that plan with you at this point in time. Underneath our student experience, and this is laid out for you in the same framework in which we under the student experience and Plan B plus remote, we would have our pre-K, elementary, middle, and high schools. All grades would rotate on a 1/3 student in person on an A, B, C schedule in 3 to 4 days, blocks during the first 2 weeks of school. The district will assign students into these groups. CMS will begin a remote-only schedule on Monday, August the 31st, and then we will also be launching on August the 17th our full remote academy, which opens for all students, and that was shared with you earlier this evening. Under staffing, each school's teaching staff will provide in-person and remote instruction. CMS facilities will continue to be open for school staff. In our facilities, moderate social distancing reduces classroom capacity into the pre-K and to their pre-K to 12 students, as other grades will be 16. And then in transportation, we'll maximize school bus capacity. It will be reduced down to 24 students, and depending on the number of students attending school daily, significant changes will have to be considered in which to make sure that those students are brought to school. So at this point in time, I'd like to bring Mr. Brian Kingsley up, and he's going to share with you what the revised Plan B plus remote calendar looks like.
Thank you, Dr. Hayes, and thank you, members of the board and Superintendent Winston. While we recognize that learning will begin across the district for all students on day one, August 17th, we also recognize the success of any of our plans, Plan B, Plan C, Plan B plus remote, is dependent upon our ability to couple our district's resources, our meaningful teacher relationships with all of our students. This also includes the various technologies and the courses that I outlined earlier today while discussing our remote learning plan as a system. We believe, based upon your feedback, that the first 3 weeks of school would be an incredible opportunity to tackle this process for all students in 3 tracks. During the first 2 weeks of school, as Dr. Hayes eloquently articulated, we recommend that each track would be able to come to school 1/3 of our student body at a time in an in-person experience for up to 3 to 4 days to participate in this process. This will also include instruction, and it will also include continuous learning opportunities. It's important to recognize that while we can't orient many of our students remotely to everything that they need to be successful, if our families choose to participate in the full remote academy, we know that we will need to provide these opportunities in a digital environment, and I think it's important to name that. We can ensure during this time that all of our students have the opportunity to meet their new teachers, get an opportunity to get oriented to their new Canvas courses, and return, reissue, and receive all of the necessary new technologies that will be critical to ensure that they can access teachers and instruction both at home and while they are in our school buildings. It's also an incredible opportunity to begin working on screeners, social emotional learning checkups and screeners to make sure that our instruction in all of our system supports are targeted to the individual needs of our students across the system. As you have an opportunity to look at this calendar, we are recommending that there are 3 tracks, Track A, Track B, and Track C, that applies for all students in the system pre-K through grade 12 that do not participate in the full remote academy. And they would come beginning on August 17th. Track A would come in 3 days, consecutive days. Track B would then be coming into our schools, our brick and mortar facilities on Thursday of that week, and have a 4-day experience, and I'll explain why in a moment, why it's 4 and not 3. And then Track C will come in the remaining 3 days of the second week of school. We have 4 days for Track B because we have anticipated in the event that we have to be nimble and agile and move across district plans, that all of these days and tracks over the course of the entire school year, we created parity for all of those tracks. And if you wanted to see, like, the next week after Labor Day would be a 4-day week for the B track. It's important to note, as Dr. Hayes articulated, that the remote learning days for all students under this proposal, not this proposal, but based upon what this thinking is, based upon your feedback, would begin on August 31st for all students and would continue until further notice as we're directed by the board. If you have any questions for our consideration, we're happy to entertain them at this time. Thank you.
All right, so I think we're going to start with a motion, and then we can do Q&A and debate. And before we do that, I just want to remind everyone who's watching in the community and remind us that there is no right answer. Then there are big drawbacks with every possible iteration of every possible plan before us. That's the situation that we are in right now. And so let's all be kind to one another and understand that we're all approaching this following the data the best we can and balancing all of this in the best that we can. So with that, I turn to Ms. Shipp for a motion.
Madam Chair, I move to approve the plan known as Option B plus remote to ensure the health and safety of students, in addition to the outlined parts listed below. I further move to instruct the superintendent to implement that plan for the reopening of the 2020-2021 school year. The school calendar for the 2020-2021 academic year entitled B plus remote. For the first 2 weeks of school, Students will be separated into 3 groups or tracks per school and will attend school on a rotation of in-person and remote learning per school calendar, B plus remote. Beginning in week 3, all students will receive remote instruction only. The remote learning will follow the guidelines in the board's remote learning plan previously approved by the board.
Okay, do we have a second?
Second.
All right, we have a motion from Ms. Schiff, a second from Ms. Sawyer. Ms. Schiff, would you like to speak to your motion?
I'll start by saying, as we looked at B plus remote, and I think about this plan, I think it's very important that we are erring on the side of caution always, and that safety comes first. And that we will continue to look at data, as we always talk about that word data to drive instruction. It will be data to drive our decisions as we move forward. I think, though, it's very important that children have an experience of that first day of school. The opening of school in the process is so important. And that brought the plus part of them coming for the first weeks of school. And I think it's very important, and I know teachers understand that need to transition children back to school, back to the building for the teachers, I think will be a good way to begin to feel that sense of what it's going to be like. But we're in Plan B. We also are looking at the importance of children and parents having an opportunity to understand more about Plan B and instruction and help students and parents prepare for school and get materials and resources, and whether they're in remote or in these tracks. I think it's very important that this time is provided. Therefore, I can agree with the B plus the remote.
Right, any other? Ms. Byers-Bailey?
Thank you. I'm really positively impressed by the B plus remote for the opportunity for the kids who were otherwise get lost. When we tried to go remote the last time, we lost track of people. This eliminates that. Everybody comes in, everybody gets their new technology or returns whatever they had, and everybody's accounted for. We don't have to go running down people in the parking lot or wherever. They come to school, they get their equipment, they meet their teacher, they establish that relationship with that teacher, and then they cycle through. Now they know how remote works. If they don't understand it, they can sit down with the teacher and work through it. So that when we do go the remote part, they are fully knowledgeable, and they know what they don't know. They know who to contact. They know how to contact. So, and to make it clear that the remote, after the 31st, everybody is remote until we decide we don't need to be remote anymore.
Ms. Cheek. Ms. Cheek.
I would like to make a substitute motion. Am I in order?
Okay.
Oh, let me read it here. I don't want to mess up. We've got so many acronyms going on at the moment. I would like to make a substitute motion for a new Plan B, with the first 2 weeks of school doing the rotation where each track comes in to pick up supplies and get their orientation. Week 3, all students are remote, giving staff a chance to take a pause and make sure there are no hiccups in the system and make sure things are moving smoothly. Week 4, we begin school rotating on our 3-week schedule, very similar to exactly what they presented on July the 1st, Plan B, our original Plan B. I'm going to call this Plan B double plus. And do I have a second?
Second.
All right, so we have a substitute motion from Rhonda Cheek with a second from Sean Strain. Do we have any discussion and debate on the substitute motion?
I will speak to my motion if I may.
Okay.
Based on the clinical data that we heard tonight and the comments that we heard from Dr. Redfield from the CDC at our county on Monday, combined with Ms. Harris, our public health director here in Mecklenburg County, the question was point blank asked, are we ready to open schools? Our medical experts have said that it is time to open. The time will not change over the course of the next 18 months. We are not going to be facing anything any differently. When asked staff, are you ready to open schools over the last 24 hours? I've had every person on our staff, Matt Hayes, Dr. Frank Barnes, Carol Stamper, Dr. Brian Kingsley, all say we are ready to open schools on August 17th, should the board decide to do that. So we have our staff saying that we're ready to open schools to students being in the buildings. We have our public health department saying that we are okay to open schools. We have our medical experts here saying that they will send their own child to our schools when they open, if they open in person on August 17th. We are giving parents and children that have health concerns the option of a really incredible virtual online choice that all of them are able to do if they need to. Just like our physicians said with nurses and healthcare professionals that had anxiety or that had issues and could not be present, we will have remote options available for our staff that, because of health concerns, may need to join that remote academy. And the last thing I'll say is on a personal note. It was very poignant to me when Dr. Oldham, the female Dr. Oldham, said how anxious everybody was that first couple weeks that they had to go back out in the field. This board had a meeting on March 13th and set forth the path to close schools. That weekend I had a patient that I had to visit in the hospital. I don't do hospital visits often, but ironically I had to go Saturday and Sunday. Each day I was so anxious. I asked my family to all leave the house so that when I got home, I could remove all my clothing and shoes in the garage, put everything straight into the washer, go straight into the shower and scrub. I Lysoled my car. I Clorox wiped my car. I took a paper bag with my paperwork in it instead of taking my actual briefcase to the hospital. I was so anxious. I started taking my temperature every 2 hours. I worked that way for 3 or 4 days. I was so anxious. By day 5, I forgot to take my shoes off in the garage, and I realized I'd walked around my house for 2 hours after I'd been in a doctor's office, and I was terrified that I had now just given my family COVID. By day 6, I realized that I came home and wore my clothes and wore my dirty shoes in the house, and we were all still okay, and nobody had a fever. And every week since then, I've gone to work as a nurse, and my anxiety is less. I wear my mask, I take precautions, I wash my hands, I insist that my teenager does the same and my husband. And I'm vigilant, I'm aware, I'm cautious, but I'm not anxious anymore because I have a job and I'm very blessed to do that. I want to give our parents a chance and our children a chance to get back in the schools because of the reasons that Dr. Redfield and Dr. Little and everyone else spoke about. We are not at a zero risk. Whether we're in school or not, there are risks that our children face. This virus is not going away. And so I want to propose that we need to get our kids back in the schools to see how we can do. Our staff says they're ready and I have confidence in them.
Dr. Jones. Microphone.
First, be safe. We have to balance between the, quote, normal daily life against the spreading of COVID. We are sterilizing environments constantly. We have face masks, and I tell you, the hours I've sat here in this face mask, I think I'm about to pass out. 5.5 hours, students, face mask. Big deal for teachers to monitor that. Maybe forehead scanning, hands sanitized regularly, spatial distancing, more time. We'll spend more time monitoring than we do teaching. We have to do extra partnering with parents, which for some communities is extremely difficult. Yes, my colleagues listen to some things and some of us listen to other things. I listen to such things. So much we do not know about COVID. Our response plans, how tight are they? We need the time to get teachers more comfortable. Not just teachers. Everybody is in a state of angst, questioning. We don't know. Now, if I recall, Superintendent Winston, pre-COVID, in those normal times, we had about a 70 teacher shortage. Where will we be if we delve right into that pre-COVID normal? 70 teachers plus how many more? What does that mean on a real day-to-day basis? It means that we crowd students into classrooms. Size, much bigger than the state allows, and certainly in COVID times than health requires. So, yes, when fears are based on genuine concern, I don't even want to call them fear. I want to call them common sense, questioning, and reluctance. There are things that we need to do to make our employees feel safe. I heard time and time again the massive amount of work that took place to make their employees feel safe. I'm sorry, CMS, we have not done that. We need the time to do that. We also need the time to have teachers engage however way with homes so they can partner. There are relationship issues in normal times. Just look how massive the work is going to be now. So, the last point I want to make, I think, is some of our schools are just not healthy environments. If you go to certain parts of town, yes. But I said it and mentioned it, I don't know how many times. I'm just going to use this example. I have been an educator a lot of years. 2 times I've been to a school environment. One time at a charter school in Raleigh, and I left, I had tears in my eyes. The second time was at Berry Hill Elementary School. My Lord. Visit there. You think you're in a third world darn school district. So there's inequity. We can pass that judgment of how we felt and how we are now reassured. But there are some reasons that some of our people are not going to be reassured. The spaces, the environment, the lack of support, the conditions that they know that will greet them. I used to hear quite a bit from Eastway, I'm just going to be frank, Eastway Middle School. They would have 7 teachers out at a time. What did they do? Disperse and bounce, or bounce and disperse? What is it called, school folk?
Disperse.
Okay, bounce, just disperse. Okay. So we've got real life issues to talk about that in normal times, they were not acceptable. They were hard to deal with. Teachers had to take morale days off. But now, those same issues, if we were to try to go back to normal, would intensify. Look at all the schools in all the conditions and not just see that little tiny peephole that you know is your truth, so to speak. Thank you.
Before we continue with the debate, I'm just going to sum up for the viewing public the difference between the two motions. So the first motion, I'm going to put this into general English terms. It's essentially a short period of in-person onboarding for students, meeting their teachers, socially distanced in smaller cohorts, followed by moving into remote learning for a period of time. The substitute motion, if I'll put this in plain English, and of course tell me if I get it wrong, but it is that short period of onboarding followed by a week off, a week of remote, followed by moving into Plan B, where, like we had talked about before in our July 1st meeting, where you have a cohort that goes to school for a week and then they're off for 2 weeks, and then the next cohort comes to school for a week and then they're off 2 weeks. So it's a difference between this onboarding in-person time, socially distanced with the original motion, then you move into remote learning. And the substitute motion is you continue with Plan B, which is socially distanced in the classroom. Do I have that right?
So I would just add that on July 1st, we talked about Plan B, and there was a component of that with seniors.
Right.
That is no longer the case, right, where they were split out.
Okay.
So that's not the case during the first 2-week period, and it wouldn't be the case after, starting from the 4th week as we rotated into the 3-week rotations.
Right, okay.
The seniors would go just like the rest of the high
Right.
school students.
Okay.
I think that's the most significant difference. I would ask staff if that sort of encapsulates the most significant difference.
It does, but also I just want to make sure it's clear that when students are on those third rotations, that they are in person during one of those third rotations, and for the other 2/3 of those rotations, they are on a remote learning environment. I just want to make sure that everyone knows they're still learning. They're not technically off. They are going to be required to be in a remote environment for those 2 weeks as they process through that. Yes, ma'am.
Okay.
And also just so this. Also want to just make sure that everyone knows that, referring back to the days that you were speaking to, as far as the 5 remote learning days for all students, which were mandated in the Senate Bill 704, is what would take place for those 5 days. So those days have to be built into the calendar that you referenced, and just want to make sure that everyone understands that after that 2 weeks, the 3rd week in either one of those would be the days that are required for that remote week, as it's laid out in Senate Bill 704.
Okay.
Chair Dashy, for expediency, you can go ahead and call the question on the substitute motion, so depending on the direction that goes, we can move forward.
Madam Chair,
Yes.
if you think it would be helpful, I would ask staff to build on your recounting of the motion to present calendar B, if it would help provide some clarity as part of this discussion.
I think we're ready to call the vote. Thank you. All right.
I'd like to speak, please.
Well, I think we're calling the vote.
So I don't get to speak.
All right. All in favor of the substitute motion, let it be known by a show of hands. Opposed? So that motion fails 7-2. So we're back to the original motion. Would you like to restate that motion?
I can, and then I have a statement. I will restate the motion. Madam Chair, we move to approve the plan known as option B, remote to ensure, B plus remote, to ensure the health and safety of students, in addition to the outlined parts listed below. I further move to instruct the superintendent to implement that plan for the reopening of the 2020-2021 school year. The school calendar for the 2021 academic year entitled B+ Remote. For the first 2 weeks of the school, students will be separated into 3 groups or tracks per school and will attend school on a rotation of in-person and remote learning per school calendar, B+ Remote. Beginning in week 3, all students will receive remote instruction only. The remote learning will follow the guidelines in the board's remote learning plan previously approved by the board.
Okay. Ms. Marshall.
Mike. It's like that mute button. I know everybody's probably pretty confused about this because this is a departure from what we had originally proposed in B and sort of C. So trying to hit some time, like Dr. Jones spoke of, we need some time to get teachers comfortable in the building. We need some time to get our remote learning working well. We need some time for teachers and staff to figure out how we can successfully get students back in the building. Most importantly, we need some time for our community to do the hard work of getting this virus under control. We know that's what works. It's masks, it's social distancing, it's paying attention to what you're doing. And we're here in Mecklenburg County with rates that we did not want to see, although I am frankly hopeful that they are stabilizing. What we all want to see is that positive rate dropping. And in order for that to happen, this is not going to all be on CMS and the teachers. This is a community issue. So we want to get back in person. And this remote learning, for me, and the rest of the board members will speak, is not an indefinite approach. This is a posture on trying to figure out how we can get folks back in our buildings. There are way more questions than answers, and we're acknowledging that right now. We need some more time, and that's what we're looking to do with this program, to get our remote learning tight, to get people started well. And to get people started well, we're going to need some in-person orientation. I think that's reasonable. And I think that I just want to say that we have an asset that we did not get to use in the shutdown, and that was our buildings. So we want to be able to utilize our buildings in ways that can help our staff and our students do a better job of the remote learning that we experienced in the spring. So I'm just asking for time, but not an indefinite amount of time. I want us to get students back in the building. We just need to figure this out a little bit better and give us more time. Thank you, Madam Chair.
Ms. Shipp.
I just wanted to go back to, when you talk about more time and what we need, I think families and teachers are concerned about daycare, and we have not really addressed that. What will our after-school enrichment programs look like? What will we do to support our teachers when those students, their own children, are 2 days off or in remote and they are in the building? So I think these are the things that we still need to be given time for, and that's critical. Daycare is very critical. And also feeding students in these different plans. We haven't really addressed how we're looking at our cafeteria workers and how we're looking at time to get these people on point and in the building, when, and we do look at full plan B. So I think that's very important and that's why we're looking at this. Do we really have these things in place and throughout our district equitably?
Ms. Cheek?
Yes, since we are going to be fully remote with these, with the exception of a couple days when children actually come into the class, we're kind of in, I guess we're going to be in B+, C- mode, basically. So now that we're going to be fully remote after week 2, which would be August, is that August 31st we start fully remote?
Yes.
Is that correct? So August 31st, we're fully remote. We have a lot of staff that is not going to be able to assist in teaching remote. We have a lot of schools where there are cafeteria workers. We have bus drivers that aren't going to be needed after that first 2 weeks of experimental orientation. We have people in administration that aren't really going to have anything to administer because the children are going to be in their homes under their parent supervision. So I would like to ask staff if they have any ideas of how do we offer pay to bus drivers, to cafeteria workers in non-essential feeding sites, to the people that don't have work to do during those during this period of indefinite remote learning. What will we do with them? How will we pay them? Will there be layoffs necessary? How many jobs would we estimate that would fall under this? That would be one question. If there's anyone here that can answer.
Yes, thank you, Madam Chair. Is it?
Oh, yeah, please.
Okay, great, thank you. Thank you for that question, Ms. Cheek. Just for context, we have approximately 2,100 employees, staff, who are in positions that cannot be done remotely or who will not have work available if students are in classrooms. And we anticipate that would cost approximately $3.8 million every 2 weeks to pay staff who are unable to work remotely, who do not have work available. We do have, as you recall, the board approved back in the spring local leave dollars and up to 80 hours. And so those funds are available. We do also believe that we could provide, for example, for our bus drivers, we could provide an additional week of training for them. I think the danger is if we're out for an extended period of time, I think that's when the concern kicks in, and we would look to continue to partner with our local partners as well as our state partners to help us provide those necessary resources over an extended period of time.
So we would not have to lay people off after two weeks with the 80 hours of pay that we have built up for them now?
Yes, we should be fine for a few weeks, but for an extended period of time, then we would have to have some additional conversations about how we would move forward.
So at the 3-week point, we would probably then have to be facing, I mean, this plan isn't indefinite. So I think we have to be working on solutions to how we're going to pay these people. And I mean, then it becomes a challenge of why would somebody work if they cannot work and get paid? So if we're going to have people sitting at home getting paid that aren't actually working past the time where we've got the approved 80 hours of pay, I think that we're going to get into some employment challenges with the staff that are working hard on behalf of our children. I had a couple other things, but that was the big one. There's got to be some kind of give there in how we're going to take care of people that cannot work remotely. And then I guess my other question to the board and to my colleagues, we talked to some medical people today and got some good information from them. Is the board or is staff going to put together a set of metrics that say, here's when it is okay to pivot into Plan Q? I don't know what we're going to call it. The governor calls it Plan B, which is where kids are actually in school. We don't actually have anybody in school after August 31st, so kind of really not in B. So we're at 0% capacity. So are we going to put together some metrics or some measurables that say if these numbers happen, we're safe to go back? We feel safe to go back. We've got doctors that said it's safe now, but Are we going to put together some kind of metrics, or is it just going to be, is it going to be a data-driven decision at some point? Is there a plan to do that? Is there a group that's going to assemble that for us?
Ms. Sawyer?
I'd like to speak to a couple points. One is...
I'm asking staff. I'm not asking another board member for her opinion on this.
I thought you addressed that to
Board leadership, or to the if board leadership could answer that question, that would be very helpful.
I don't see this as a forever remote. I see this as something that gives us, we need time to, we need time for the community to work together to lower the COVID infection
No,
numbers.
I understand all that. I'm just, are we going to make actual
Do not
measurements?
interrupt me. Thank you. I have the floor.
You sure do.
It is incredibly urgent that the city, the county, CMS, our partners in the towns, and everyone in the community keep pushing on wearing the masks and the social distancing and following the common sense public health rules to bring down the infection numbers to the point where we can safely return to our under-resourced schools, get our kids back in school, get our teachers back in school in a way that is safer than it is today. And our health depends upon it, lives depend upon it, jobs depend upon it, and education of our children depends upon it. So we need that to happen. And we cannot wait forever for it to happen. It needs to happen as quickly as possible. But we're just not there yet. That's my sense of it. And so I think we do need a metric.
Thank you.
New York City, New York schools have a metric. I think we need to work with our public health partners to develop that. And I think we need periodic checkpoints, not long, I'm not talking about a quarter, I'm not talking about a semester, I'm talking about whether it's weekly or monthly. We need periodic checkpoints to say, okay, are we ready? Are we ready to go back to B? Because we need to get our kids back in the classroom as soon as possible.
That's all I'm asking, is that we work together with staff, that you work together with staff, you can include board members, whoever needs to be, but we need to work with these experts that are here and are ready and want to work with us, because they realize the sense of urgency of this. We need to develop we can't just say when it's safer, we need to actually have some metrics around that. I'm supportive of that. I want it to be safer. Mm-hmm. They thought it was safe tonight. That did not prevail with this board. That's okay, but then we have to get actual data, not just an emotion, but a number, to make a good decision in the future.
And it's not just the metrics, it's also the safety on our side. We need time to truly ensure and be able to show our families and our teachers that our buildings are safe. Ms. Sawyer.
I think the most telling moment about our school safety and the conditions were when I believe Ms. Dashu asked one of our guests if he would send his children to a school that had a 30% infection rate in the surrounding community. There was not a quick yes to that question. There was a rather pregnant pause and a non-committal response. Mm-hmm. And I think we have to deal with that. That is my neighborhood. That is where I live and the district I represent. If we have someone who is generally in favor of reopening schools in person rapidly, has that kind of reaction to the local conditions we face, that gives me pause. The other conversation I had during the break was about masks, and I chatted with one of our guests about masks, and we joked about how watching our colleagues, medical providers included, playing with their masks, messing with their masks, touching their masks, all things you're not allowed to do. And we talked about the challenge of children wearing masks for a 7-hour day. And that is a serious challenge. We also talked about mask availability, and I said yes, and CMS is going to be able to provide 5 masks to every staff member and child. And he said, well, for how long? I said, no, we're providing 5 reusable masks for everyone. And he was aghast. We are not doling out fresh PPE throughout the day. We will not likely be able to provide, a change of mask midday after lunch, which would be probably better practice. I know that our facilities staff has been working for months to stockpile cleaning supplies of all sorts. But I also know that they're finding that some kinds of supplies are just not available. And they may be available soon, things like sanitizing wipes, the kinds of things that would be in a classroom for a teacher to wipe down a table or do a quick cleanup on a high-touch surface. We don't have a stockpile of those. And we need time to amass the equipment that we need to keep our students safe. I mean, we have a little bit. We can get through a couple weeks, but we don't have that. I'd also like to urge us to think creatively and out of the box about how we can use the skills of our employees who would normally, our bus drivers and people like that, who won't have normal day-to-day activities, their usual day-to-day activities during the periods when we are in remote learning. These staff members have lots of skills. Many of them live in the communities that we need the most help in building relationships with. I know some bus drivers who would be amazing community resources in their local communities if they were resourced and given some basic training in help assisting with logins, to have some basic skills and maybe be provisioned with a laptop so they can assist their neighbors. I think we have an opportunity to look at our staff and find these staff members who are bilingual. And can we provision them to assist us in ways that are outside of their current job description, but are essential in this new reality? And I agree, ultimately, face-to-face unmasked is, the way people learn, but that's not where we are right now. I hope with Ms. Marshall and the rest of my colleagues that we can get there as quickly as we can. The CDC person that was here speaking the other day talked about if folks practice social distancing and masking religiously for 6 weeks, we could squash this. Well, we have 6 weeks. Our community has 6 weeks to make sure that we can more safely open schools sooner, and that we won't have to worry about unemployment gaps. But it's going to take a concerted community effort to do that. So I invite my community members to help us out, and I think we can do this. Thank you.
Okay, Ms. Delahara?
Thank you. I also heard from our presenters tonight, several unknowns, things that they, weren't able to confirm because there's so many things about this virus that we just don't understand. I did also hear one doctor mention in passing that the rates are going down in Europe. And I made a little note of that, and I don't remember who said it. I can't attribute it, but I think that's an interesting statement, the way that it was presented, because many folks today are suggesting, well, Europe is opening, we should open, but again, that is the truth. Their rates are going down and ours are not. So I just think that's really important that we keep that in mind, because we're not in the same situation necessarily. I'm hopeful that we're going to do our part, as Ms. Sawyer said, but that's just not where we're showing right at this time. Another, I believe it was the first doctor, Dr. Little, said this, forgive me if I'm wrong, but I thought he made an interesting statement, and he said one of the things they decided to focus on was the question of what are we going to stop doing so that we can focus on other things. Mm-hmm. And I thought that was really poignant, because I'm not sure of us asking our teachers to go back in with all of the uncertainties and the lack of the robust programming that they talked about, which I think we could hopefully all agree that 5 masks does not constitute robust. As the anxieties are there, the lack of proper PPE or whatever the situation may be, the teaching that has to go on, what exactly are we going to ask our teachers to stop doing so that they can focus on everything else? I'm just not sure that that we're going to be able to do that in the way that he described, that's what they had the luxury of doing, if you will. I just thought that was an important point to point out. And then they did confirm tonight that the mental health of the teams that they worked with was a priority. And so I'm glad that you brought that up tonight, Madam Chair, as well, and maybe some others did, because I do think it's really important that we consider the mental health of our, not only our children, but also our staff. And in fact, I'm going to read a little bit of this, if you'll bear with me for a moment, but the National Association of school psychologists, not just any psychologist, but I think that's important that we point out. They published a statement paper the other day where they also agreed that, yes, they talked about the school mental health of children, but they talked about how preparations must be made to support staff members' ability to work, and that additional staff must be hired to manage the complex academic and mental health needs described above. And I'm sorry, I'm not going to read the whole thing. I would encourage everyone to go and look that up so that we can read as they go on. When they talk about many things related to the mental health of the staff, they go on to talk about, for schools to reopen safely, there must be attention to each school building's physical design. Dr. Jones mentioned this. Ventilation systems, capacity for school distancing. I'm not going to read all of it. The educational and health needs of students and staff, the capacity of schools to meet those needs. And they talked about how the one size fits all or open or anything else statements coming from our government officials fail to acknowledge the complexity of the current situation and the ethical responsibility of educators to do no harm. For school leaders to meet the complex demands of this crisis, they must be empowered by not just words, but also evidence-based guidance and the substantial financial investments necessary to ensure that our nation's schools can safely return to in-person education. If we are serious about returning to in-person instruction, we must first prioritize lowering rates of community spread. Public health officials are best equipped to direct these efforts. Unless significant reduction in community transmission has been accomplished, a return to in-person schooling will result in unnecessary illness and death. Schools that return to in-person learning in communities with a high level of transmission will be placed in an impossible position. They likely will face the need to close again because of the outbreaks and will be blamed for an entirely predictable failure. Even in communities that are successfully controlling the virus, in-person schooling will require new and substantial financial investment. We must commit to providing schools with the funding they have repeatedly asked for to ensure that they have the resources required to implement CDC guidelines and to protect the health of students and staff. And of course, they address the mental health of students. I think we all can agree that that is a concern of ours. I'm not reading the whole thing, but I think it's interesting that they're also making sure to be inclusive, that they know that the mental health of our students also depends on the mental health of our staff and our ability to evaluate and respond to all of these needs. So that's why I'm bringing that up. I'm also going to repeat that the CDC director was here yesterday, and he made the comment here in Mecklenburg County that if all of us would put on a face covering now for the next 4 to 6 weeks, that we could drive this epidemic into the ground. And I just think that that is, yes, the call. I think Ms. Marshall and Ms. Sawyer said this. It's a call a call to the community, because I don't want to be in C forever. I don't think anyone plans to be in C forever, but the responsibility is on us as a community to do what our experts are telling us to do so that we can move back into the building safely. And it's important that we put teachers in a position to be in good mental health space so that they can carry the energy to the kids. If we don't help them feel safe, we will be hard-pressed for them to effectively help our kids feel safe. And as a community, it's time that we come together to do the seemingly inconvenient things necessary proactively so that we can all benefit from the multitude of benefits that our kids being able to learn in the room that our teachers bring, I'm kind of going through my notes because I had some different things to share tonight, but I mention that because when we're talking about the community and why it's important, you know, even when I was on the campaign trail, it was shocking to me sometimes. I would tell people, hey, I'm running for the school board, and they're like, oh, I don't have kids, I don't care. I'm like, you know, shocked. Be they young or be they old and their kids are all grown. That response, there's sometimes this sense of like, oh, well, I don't have kids in the system, I don't care. And from my perspective, I always thought, well, everyone has a vested interest in the school system because we're raising literally, you know, our next generation, our future workforce, our neighbors, our community leaders. And so I think that COVID-19 is presenting us with an interesting new time to reflect on how important, in a different way, if maybe those very important, I would argue, reasons didn't inspire people, that now we can see how important the public school system is in a new way. And so I would just ask people to take it seriously, and that we mask up and do what we need to do, stay out of the crowded bars or whatever is going on, even if you don't have children or even if you're older, because it's everyone's responsibility because we are all interconnected. I think that's all I'll say for now.
Okay. Mr. Schul.
I think Dr. Jones spoke a harsh truth that we all really need to hear right now, which is that we cannot expect to make a just decision if we do not frame it within the realities of our inequities in CMS. We cannot make a decision within the frame of mind as if I was going to school. We cannot frame it within as if a privileged white kid at AK were going to school. We have to frame it in the minds of schools who are far less advantaged and far less privileged. And that means exactly what Ms. Sawyer was talking about. If we cannot confidently say that we can send kids to school in cases where there's a 30% positive rate within a certain demographic, then that is not a fair decision. And that's why I think there's a lot of equity problems that we need to address, and we need to think about deeply before we can consider sending kids to schools in any capacity. I think the fact that when we're talking about testing, if we're carrying out assessments and testing the same way that we have in the past, then students learning in person will have an obvious advantage in preparing for those assessments, and those assessments go on to affect students' futures enormously. It also means that students who have resources and technology at home and are better equipped will be able to offset that disadvantage more easily. More importantly, it means that when we're looking at schools that don't have the proper HVAC systems, that don't have the same resources as others, that those students are going to be more at risk. And that is not a fair decision and not one we should be able to make. Second, I think we need to look to teachers and staff well-being, because the fact of the matter is that the teachers at my school and the teachers around CMS are the lifeblood of our education. And if some parents are allowed to deem that the school is too dangerous to send their child to school, then we should not expect teachers to go to school without that same option. Right now, if we were to send teachers to school, there would be large amounts of teacher absenteeism, and there would not be enough substitutes in schools to cover for it. There also would be a huge workload for teachers who don't have a full course prepared for them by the district at this moment, which is why another reason I think we need more time to help those teachers and to help prepare those teachers. It's unfair to say that some teachers should have a full course load ready while others are forced to prepare in-person learning, in remote learning, and the full remote academy. But lastly and most importantly, it's unfair to say that we should make teachers go to school knowing that, as the doctors and health professionals told us today, that they will inevitably be susceptible to disease. That is something that I think needs to be at the forefront of our discussion today, and I think that is why we cannot support sending students or teachers into schools at this time.
Ms. Shipp.
And I just want to add too, because as I talked to the pediatric doctors as they were leaving, they were concerned about, and I mentioned the number of teachers that we have that are pregnant, that, and this happens every year in buildings, and how afraid they are to go back to work. And what they said was, it is reason to be. And I have a niece that, and I'll just share, that is pregnant right now, and she has had COVID. She has recovered from it, and she was in the hospital for a while, and it is scary. So I can feel that as we talk about the health of our teachers. And we've had schools where we had as many as 5 and 6 teachers pregnant at the same time. So this is real, and the risk for teachers to go back in the conditions they would be going back to, and to have those situations. And I had one to actually say, what should I do? I've already used some days and I am pregnant. What should I do? Because I don't have any other factors, but I am pregnant. So I think these are the kind of situations that are real. So when we talk about the mental health, and as Gabe was saying and Dr. Jones was saying, the buildings that they go back in, this is real. And our teachers have those concerns and stresses and anxiety that we have to hear, and we have to say, what are we going to do? And as I mentioned before, will we have a team that will manage the issues that come up and manage them quickly if someone does get sick? How do we have that in place? Are we prepared to do what will be necessary to ensure that we don't have quick spread? And I think, again, those things are not in place right now.
Ms. Marshall.
Before we go too much further, I just want to acknowledge that our staff has been working around the clock for some time to get us to a place where we can go back. And so there are a lot of things to be worked out. But I can't, it's not for lack of effort that we are here. Mm-hmm. I just can't say that enough, because they have just done Herculean work to to figure so many details out. So I think we really do have a head start on this. So I want to maximize that time. What I'm hopeful is that a couple things are going on. I know early in the meeting our feed was a little dicey. So we had an incredible presentation on a virtual school that families across the country are very interested in, but they really should be interested in it here because it's so well done. And that's going to open up on Friday. So I want to tell parents to make sure that you're aware, teachers are aware, that this is an option for you if you don't want to even mess with the thought of going back into the building for a while. Because when you take that, we're going to be able to partner teachers that are really have some issues with their health with you, and I think we're going to come up with some really good work for folks and really good options for our students. So that's really important that people understand that that is its own option that lives there by itself. And what we do now with everybody who's not in that is we're watching and we're looking at the data. We're going to be developing some metrics. We're going to be working with our staff to prepare and get ready. And those teachers that really haven't been in those buildings since March, they need to go back in and see what it feels like, what would make them comfortable, what would make their children comfortable in order to get here. So I think we can do this. Again, there's a cost with this safety. And so we want to make sure that while we cannot eliminate all risk, we want to mitigate risk, and we want to mitigate any job loss. So we've got to be aware of that. It's so important. So I just want folks to look at their options, and we're going to do more messaging on their options so that they understand that and understand that there are no easy decisions here. We're trying to lead with safety and time, and that's why I'm in this voting position that I'm in now.
All right, I'm going to go ahead and call for the vote.
May I speak?
Oh, sure. Okay, I'm sorry. I didn't see your hand. Mr. Strain.
Sorry. So, I mean, we've been here for over 5.5 hours. We're into this critical meeting. And we've heard from our staff and our community health partners. The way that CMS works is we have a Board of Education, 9 members, and we employ 2 individuals, our general counsel and our superintendent. So we've had a presentation, and it's called B plus remote now. And I just, usually when we go down this path, there's a recommendation. Is this, Mr. Superintendent, your recommendation of staff that this is the best course of action for our students and staff?
Almost forgot, Mr. Strain. The B+ remote option, we believe, is the best course forward.
Okay, so that's your recommendation. So what we have is our services, our K-12 services, I certainly deem as essential services. And we've seen essential services throughout the country layered on. There's other things that have been layered on in terms of adding risk and exposure in terms of the COVID virus, which we could certainly argue are not essential services. Restaurants, bars open at 1 a.m., not sure those are essential services. In-school learning, I think we can argue are essential services. So being 5.5 hours into this meeting and heard from all sorts of experts, including our own talented staff, our medical partners, I didn't hear a single reason, not a risk, but a single reason to go fully remote. We were asked time and again by the medical professionals to put kids in school, to put their kids in school. Our team is on track. It's on track for academics, and it's on track for operations. In fact, it's on track for safe operations. The public health officials are confident, as we heard tonight, in the ability to manage this outbreak. With increasing concern regarding youth health issues of being out of school and at home. They mentioned suicide, overdose, child abuse. One of the doctors mentioned that the suicide rates are going to be tremendous in comparison to COVID in terms of the youth population if we don't get them back in school. Our regional healthcare systems are prepared and available to serve. This risk is known and mitigated. The continued risk and escalating issues associated with our youth is actually being out of schools. And it's a very significant set of equity issues with the remote learning plan. And yes, Gabe, even more significant than in the schools. There's clear and broad agreement on the very significant incremental value of in-school learning. There's another note I have here that as it stands, we don't know when we're going to come out of this. There's no metrics, we don't know. And we just discovered, well, in mid-September, we're likely to furlough 2,100 personnel. We don't have any other way to hang on to them. But it's okay to put students and staff into schools for 2 weeks.
Just one second, I just want to do
not any longer. I'm speaking
one
in
correction of a
opposition.
fact, though. Is that, Mr. Superintendent, is that, can you clarify that?
With regard to our hourly employees,
Yeah.
So when you take into account the first 2 weeks of schools with the onboarding rotation process,
Yep,
and then we also believe we can provide an additional week of mandatory training. And in addition to that, the up to 80 hours of the emergency local leave, we think we'll be fine for about 5 weeks.
And then
Yeah, so that's
turn into our
mid-September.
partners
That's what I said.
for
That's
help.
exactly what I said.
Okay.
That's how I calculated it, actually. So the point is that it's okay. It's okay to send all of our staff, our students, to school for 2 weeks. Just not any longer. I don't understand that at all. So I'll be opposing this plan. Thank you, Madam Chair.
All right, so before I call the vote, I will just acknowledge again my gratitude for the medical professionals that presented to us tonight and answered our questions. And they acknowledged that this is a tough call and that this is our call. And we are gathering input and data from dozens of different fronts, including the medical front. And I did not hear a medical professional say, I am telling you, you need to open your schools. I heard them say, this is a tough call. Here is what I know based on my perspective, but I wouldn't want to be in your shoes. And so I just want to clear that up. I don't want it to be framed as though they told us what our vote should be or what our plan should be. Because that's our job. That's what we got elected to do. Lucky us. And so with that, sure, Mr. Superintendent.
Thank you, Madam Chair. I just wanted to let our families, our teachers, our principals, central office staff know the first 2 weeks of the onboarding rotation process, I think it's important to articulate that we're going to plan that first 2 weeks with the input and help of our teachers, our principals, central office staff, and our families. I didn't want it to come off as something we're doing to individuals, but rather something we're doing with them as a collaborative process.
So we're going to have this onboarding, socially distanced, small groups of students coming into the school for an in-person onboarding before we go full remote. And what that looks like and when you come in is you're going to be working on this with teachers and principals.
Families as well.
And families to make that as effective as possible. And so that is sort of to be determined. That's not baked into this motion right now, those details. And if you're a parent and you're following along and you're going, oh, I'm so confused, when do I bring my kid to school? We'll make it simple for you. You will get a letter in the mail, or you'll get an email to walk you through that. So we will make it simple. I know this sounds very confusing when we talk about it at the dais in a motion. It was, written to fit our legal requirements with the statute, but we'll put it into plain English and make it simple. All right. Anything else that we need to clarify before we move to the vote?
No, well, the only other thing I would add is that, I know that we've got hourly employees who are watching. We will continue to advocate on their behalf to ensure that they're taken care of, and I just wanted to articulate that as well.
Yes. All righty. So, all in favor of Ms. Shipp's motion, please let it be known by a show of hands. And I see 7 hands. Any opposed? I see 1 hand, and I'm guessing 1 abstention. Okay. So, Madam Clerk, the motion passes by a vote of 7-1 with 1 abstention. I want to thank everybody for their hard work, and especially thank our staff for their hard work, because there have been a lot of twists and turns along the way. So thank you for your fortitude and flexibility. And as we keep saying, we'll get through this together. So I will now entertain a motion to adjourn.
So move.
Second.
All right. We have a motion and a second. All in favor, please raise your hands. Any opposed? We are adjourned.
Lord have mercy.